So I'm going to explain how migraines are connected to chaos theory, and this is going to be pretty difficult. This has taken a few months to piece together and do, and this started off as a very small project of just me trying to explain a few scientific papers, which I will get to at the end. But when I realized no one on YouTube has ever made a video on this, I was in shock. It seems like anything that's ever been discussed is already on YouTube and discussed ad nauseum. It makes sense, though, in that who's going to care about this other than someone who's disabled with migraines and sees the connection? And it is the heart of the disease. And it isn't some esoteric academic connection, because migraines are a disease of management, and there is no cure. And you're not going to be able to manage something you don't fundamentally understand. So I've split this into 3 sections. First, I'm going to do this overview, introduction, and then I'm going to get into some reaction videos just on a lot of general information on migraines and a lot of very difficult to find. And I've sort of ordered and spliced the videos in a certain way that they proceed along a progression of further and further clarity of what's really going on. And then it connects to chaos theory, and this should all make perfect sense at the end. So the brief overview, migraines are a consequence of system dynamics, in that a migraineur's body is particularly sensitive to disturbances. In math, you would call these perturbations, but in medicine, they're called migraine triggers. And these triggers cause a cascade, which causes the system to transition from a state of order into disorder. And that system is the brain, and the central nervous system interprets and processes disorder as pain. So what's important is that this process is self-amplifying, and that through a network of feedback loops, it makes the cascade easier to happen again and again for the process to keep repeating itself. So the more it happens, the easier it is for the body to be attracted back to that state and for it to happen again. So for someone like me who grew up with migraines, my body got stuck in the vicious cycle a lot easier. So I'm going to go through a few analogies that might help. And so migraines are unique in medicine in that they are the only disease with a bidirectional relationship between the symptoms and the triggers. That means like the triggers are causing the symptoms and the symptoms are causing the triggers. So in other words, imagine you had a terrible cold and you had a terrible fever, and the more you coughed and sneezed, the more you sneezed and coughed. And there's this feedback loop. And you would essentially have a cold for the rest of your life and never get better. And that is potentially what's happening with a migraineur. They're managing their triggers with these feedback loops. And the only other way to explain that is if you imagine an allergy. So there's nothing wrong with pollen or dander that is causing the allergic reaction. It's the immune system that is overreacting. So these external environmental stimulus that are causing the migraine triggers, it's the central nervous system that's overreacting. It's causing this cascade into disorder. So I want to give an overview of chaos theory itself, and just as complex as it sounds, there are some simple components that anyone can understand, and it is fundamental to how nature actually works in a hidden way behind the scenes. And it is one of the major discoveries of the 20th century that is very easily overlooked. And what's difficult for it is that it is improperly named. It gives this sense of just pure randomness, whereas it is order masquerading itself as randomness. And that when you look at systems very carefully, and like when they cross the threshold of complexity into a chaotic state, you can analyze the randomness and the patterns emerge and sequences. And it is latent order. That is order that appears over time as the system sort of evolves. So when it comes to system dynamics, it's not that far-fetched to understand how migraines are connected to all of this. And we discovered chaos theory by analyzing macroscopic systems. So this didn't come from pure math, like someone sitting down with analyzing equations and doing calculations. This came from observation of physical systems, of the weather, and through astronomy of the three-body problem. But it also took computers, because in terms of putting the equation over and over again and having it feedback into itself and having it mapped out over time, seeing that latent order over time. So, but it's also been seen in biological systems. It's been demonstrated in biological systems. In terms of it being inside of our body, our powers of observation are just get much more difficult to exact the exact mechanisms that are causing the cascade and all the consequences therein. And the expertise behind it is even harder because applied mathematicians don't have medical degrees, and neurologists never took a class in applied mathematics. So if you're wondering where all of this came from, that's a fair question. And it came from one of my initial inspirations to write, which is from Dr. Oliver Sacks, the neurologist, and this book, The Man Who Mistook His Wife for a Hat. It sounds like a comedy, but it's about people with rare neurological disorders and how they experience the world very differently because of them. And it's the point I realized I have a rare neurological disorder that's actually quite common, but I do fundamentally experience the world very differently because of my experiences with them. And what's interesting is his first book is on migraine in 1970. So this was written in the year I was born, in 1985, and this was written in 1970 under the initial title Evolution of a Common Disorder. And when it was reprinted in 1991, it lost that subtitle. I wish it had not, because I think it's an important component to describing the disease, that it changes over time. And it was in this edition, the one that I read, that he describes it being connected to chaos theory, and that the idea that the migraine is a strange attractor in terms of in-system dynamics. So, and when I read that, I was sort of startled when I eventually came across this in my late 20s, early 30s, actually. This was something completely new to me, because as a teenager, I had been to the best neurologist, the best headache specialist. I went to the Mayo Clinic as a teenager. I saw a panel of neurologists. I described my health, and I showed them my headache chart, and they were baffled by it. And at the end of it all, the neurologist just said, well, we don't know what causes it, and it'll probably get worse before it gets better. And that was a tough pill to swallow, and at that point I'd already nearly put a knife through my head. It was so bad. But I did not, and I waited, and I took that advice quite literally, and I laid in bed for a decade waiting. I had this false sense that it was somehow connected to being a teenager and getting up to the age of 25, when your body officially stops growing, that the pain was connected to that. And I got past that age, and it continued every day, and it's now been 25 years. And I wish I knew then, as a teenager, I wish I could have read that book then and known then what I know now. But after the first decade, then I began to write, and I did not get to touch on this as much as I wanted to in my writing. So now I'm going to go through the videos and all the things I wish I knew when I was young. For every video that I'm doing a reaction to, I have 10 that I've reviewed and listened to, and some of them are really long. Some were like 3 hours long. Dr. Andrew Huberman had a 3-hour-long video that had millions of views, and I didn't find it useful. All the information is covered here in other better videos. But in order to do this, I had an old relic, because this is torture, watching them all over again. This is an antique birdcage. So when my sister graduated from high school, my mother set this out, and people would put the envelopes for her graduation party. And the symbolisms of the bird is sort of flying away. I didn't have a high school graduation. I was growing up in hospitals, but so as a teenager, when she was gone and this thing was still laying around, my parents were annoying me with constantly asking me, like, what number's your head at? What number's your head at? So when I would wake up with a headache and I didn't want to like deal with the question, I would put this over my head when I went to the kitchen table, and they would kind of bark at me when I tried to eat through the bars, but they never asked me once I had the cage on my head. So I'm going to start with this guy. He's a family physician, but there's still a lot of information here, and it's the perspective that exists outside of mainstream neurology.
Headache, you better listen up, especially if you had a migraine, because today we're having a special episode of the Doctor's Pharmacy called House Call with my colleague and friend, Dr. Todd Lepine, here at the Ultra Wellness Center in Lenox, Massachusetts, and we see so much migraines. We've just been at the forefront of this whole movement of functional medicine, and I would say migraines are among the worst condition that people can suffer from. But from a functional medicine perspective, they're probably the easiest things to treat. Wouldn't you say, Dr. Lepine?
Absolutely. Yeah, exactly.
So how do we think about this condition in traditional medicine? What is the normal approach to diagnosis and treatment, and what's wrong with it?
Well, the interesting thing is when I look back, I can remember when I was practicing mainstream medicine, I always looked at migraine patients. And there were so many different things that were offered by mainstream medicine for migraines. And it sort of made me question, like, there's no such thing as one migraine. There's so many different flavors of migraine. You know, you can have a patient who has periodic migraines. You can have someone who's got menstrual migraines. So to me, that was telling me that migraines, there's a lot of pathways to developing what we call a migraine. And I found it really is an interesting approach to know that each individual, their presentation for migraine is unique. The interesting thing is I would never treat two migraine patients the same because they all have different features.
So that speaks to a very central idea in functional medicine, which is this. Just because you know the name of your disease, it doesn't mean you know what's wrong with you, right?
Absolutely.
You have a migraine, that just describes people who have a certain type of headache with certain types of symptoms like light sensitivity, noise sensitivity, maybe on one side, maybe visual pre-aura symptoms, nausea, vomiting. These are just the typical things. Okay, you have a migraine, and then we divide into classical migraine and this migraine, and they're all just different ways of describing the kind of migraine, but none of them tell you the cause. So functional medicine is about focusing on the cause, which is what you're talking about, these different flavors. And there may be up to like 29 different factors that can drive a migraine, and traditional medicine just uses a one-size-fits-all approach.
Yeah.
So what is the typical approach to treating migraines?
Well, in mainstream medicine, it's really just basically abortive therapy. You know, you might take Advil or Aleve or an Excedrin. You might take a triptan. You might take an opioid.
Like Imitrex or something.
Imitrex, yeah, Imitrex, exactly. Or opioids in severe cases, steroids in other cases. So it's basically treated abortive therapy, which is that when you get an attack, you treat that attack. And for people who get them more frequently, it's about trying preventive therapies, and they're all over the place. I found that actually quite interesting when I was looking at, how do neurologists approach migraines? These headache neurology specialists, and they use everything. They throw everything in there. They'll throw in beta blockers. They'll throw in calcium channel blockers.
These are to prevent migraines. To
prevent migraines, exactly. So so the preventive role is really important, I think, because when you look at someone who's suffering from migraines, I mean, people can lose a lot of work over migraines. They
debilitating.
It's absolutely, and sometimes for some people, it might be 2-3 days or a whole week that's lost. They're just like, they got to stay in bed and turn the lights off and just wait till the whole episode passes. And then other medications that are used in mainstream medicine are anti-seizure medications.
Yeah.
I mean, it's
so antidepressants, seizure medications, blood pressure medications,
calcium channel blockers,
all the stuff that they're kind of throwing
antidepressants, tricyclic antidepressants, you name it.
And there's no way to actually figure it out. You sort of like, it's like spaghetti on the wall. These doctors try this, try that, try this, and I can't tell you how many patients I've seen who've been through the whole mill of these medications, and it might help a little. It might
Botox. They're using Botox now.
That's
they're
right.
using botulinum toxin.
Yeah, well, that's just to paralyze the muscles in the back of the head, right?
Exactly. Yeah. Right.
So, and it's a terrible condition. I've had people who had chronic daily migraines or 20 days a month, and it's just so awful for people.
Especially in women. Women tend to have a little more. I think in general, women. I'd probably see more women with migraines as opposed to men. And then women also get menstrual migraines, which is another sort of flavor of migraines, which is another probably related to estrogen detoxification. So it really is. It really keeps me on my toes in functional medicine when I see a migraine patient, because it's not like, oh, here's your problem, just do this and it's fine. I've got to play detective. I've got to figure out what are the factors that are driving that person's unique presentation of their migraine.
So in functional medicine, we don't just name and blame, which is what our mentor Sidney Baker talks. We name it, blame it, and tame it. You name the disease. Say, oh, you have a migraine. That's why your head hurts. No, that's not why your head hurts. That's just the name of why your head hurts.
Yep.
And then we try to tame it with a drug instead of actually figuring out the cause. So let's talk a little bit from a functional medicine perspective about what the causes are. And let's get into some cases, because I think we've both seen so many cases. It's one of the most satisfying things for me as a doctor to actually treat, because it's so easy usually, and people do so well with simple approaches that deal with the root causes. So tell me what are the things that you think of when you're coming to see these patients that could be driving the migraines?
Well, one of the things that I think is missed by a lot of mainstream doctors, even neurologists, is to understand the role that mitochondria play in migraines. Interestingly, mitochondria, which are the powerhouse of the cell, they basically is where when our body consumes food, we produce energy from that food in the form of ATP. And mitochondria are not really tested by mainstream medicine. They are not well understood. It's something that you learn about in medical school, and then you forget about it. And the interesting thing is that people who have migraines also have a higher incidence of seizures. And that's why, to some degrees, anti-seizure medications can actually have efficacy in some patients who have migraines. So there's a real important to realize that connection between mitochondrial dysfunction and migraines.
Mitochondria make energy in your cells. So
make energy in your cells. In fact, I've actually seen some patients, interestingly, who and I don't treat children, but I've seen some adults. When I go into their history, they had a history of what is called cyclic vomiting syndrome, and so that's where a young kid is vomiting for no particular reason. And turns out cyclic vomiting syndrome is actually a mitochondrial problem. And as a person gets older, they sort of outgrow that vomiting episodes, but they actually then present with migraines. And interestingly, the gut is connected to the brain. So a lot of people can have what we call abdominal migraines.
Yes.
Exactly. Right.
Yeah, this reminds me, Todd, I had a patient who struggled with headaches and migraines, and she had terrible SIBO, which is overgrowth of bad bugs in your small intestine.
Yeah.
It was causing all this fermentation and creates these toxic byproducts that were clearly creating inflammation in the brain. And we treated her gut with antibiotics to cure migraine. But who would have thought of that as a neurologist, right?
Exactly. And,
so,
and it's also the other interesting, and we're going to talk about that in one of the upcoming episodes, is on histamine, the role of histamine. And that's actually a very interesting thing when you look at histamine, because people who have SIBO, they actually have bacteria that are producing toxins, like you're talking about. And one of the problems is excess amounts of histamine. So normally our bacteria will degrade histamine, and we have enzymes that do that, and there's all these different pathways. And when you look at some people who have migraine headaches, there are certain foods which can trigger a migraine. So is it the food that's doing it, or is it something in the food, or it's how the food is actually being metabolized? So that's a really a key important feature, is the connection between the gut, our food, and the brain.
Yeah, I mean, it's such a big problem, Todd. You know, the amount of people with migraines, there's over 10 million people have migraines. It costs about $17 billion a year to society in healthcare costs, just direct healthcare costs. That's medications, emergency room visits, hospitalizations, doctor visits, testing, and then even managing the side effects.
No, by tomorrow you'll barely be able to breathe.
Oh, man.
And then the loss of productivity to employers, because like you're saying, is $15 billion, about half that's
huge
due to absenteeism, and the other half is due to just people being on the job but not being at the job but not on the job. You know, they're just sort of there but not functioning.
Absolutely.
And so, you know, over the years of functional medicine, I've seen so many patients, and like you said before, there's so many different flavors. Tell us about some of the other flavors, because we went through the mitochondria, and let's just go down the list of what are the most common things, because, you know, like there could be 29 things, but there's a few that are really common.
Stress.
That are really stress. Okay, tell us about stress and migraine.
So stress by itself does not cause any diseases, but stress can turn the volume up on all different kinds of conditions. We see that in autoimmune conditions. So how our bodies respond to stress, and some people have, I would call it a genetic predisposition to be more stress resilient, and some people don't. And some people are more prone to the effects of stress. And time after time, you know, you see these people who they'll go through a very stressful period, and all of a sudden they get a full-blown migraine. Well, what is that? It's how, you know, what's going on there? And I think it is how that person perceives the world and how they detoxify their stress.
Things like yoga, meditation.
Exactly. And then also sometimes when you have patients who have migraines and you measure their cortisol levels, they've got higher levels of cortisol. So that's telling you they're having more chronic stress.
There are a lot of symptoms that people get that could be related to leaky gut. and food sensitivities, which seem to be a huge factor with migraines.
The connection between the gut and the brain is huge, and the leaky gut component, you oftentimes will see leaky gut in patients who have increased risk for migraines. There's definitely a two-way communication that's going on there. And again, sleep is another thing that plays a huge role. So lack of sleep is huge in migraines.
Well, migraines are a huge problem because so much disability, so much stress for people, and they're debilitating. Thank God there's some migraine drugs you can take to abort it. There's some preventive drugs, but none of those approaches address the root cause of migraines. Cataloging, what are the big triggers of migraines? And I'll just go through them. And it can be 29 different things, but we'll go over the big ones. The big ones are food. So often there are food triggers. Now, the typical neurologist will say, yes, there are certain foods like tyramines, like cheeses and aged foods, certain chemicals like aspartame, glutamate, MSG, we know can be triggers. So there's excitotoxins, there's certain tyramines in food and so forth. So they'll tell you to avoid those: wine, cheese, that kind of thing. Those are reasonable recommendations. But then there's a whole other class of foods that are more around food sensitivities. There are also patients who, for example, have mitochondrial issues where they can't produce energy in the cells, and they need riboflavin and high dose of vitamin B2, which is riboflavin, like 400 milligrams, which is like thousands of times more than the RDA, or the recommended dietary allowance, and even things like CoQ10, which help mitochondria. Magnesium deficiency is very common. All those symptoms, muscle twitches, constipation, anxiety, insomnia, palpitations, they're all magnesium deficiency symptoms. So she had severe magnesium deficiency. They gave her like 1,000 milligrams or more of magnesium for a bunch of days. All her symptoms went away. Her migraines went away. And that was her problem. It's different for different people. The treatment is really getting to the root cause, whatever it is. I almost, universally can cure migraines. I really have had not a patient who hasn't either completely gotten rid of them or reduced them so dramatically they're a trivial event, and if they're they're not that severe. So I think it's really a manageable problem using functional medicine. It's one of the home run treatments. There's a lot of this can be done by self-care, so it's not that hard. And
there's a reason why this prison is the worst hell on earth. Hope. Every man who was rotted here over the centuries has looked up to the light and imagined climbing to freedom. So easy. So simple.
So I couldn't help but add that in there as a tone shift, because he seemed wildly overconfident and not really understanding the true spectrum of the disease. And for those of us who have a headache every day, the efficacy of self-care is very minimal in terms of what it changes. But it's also very difficult, because when you add confusion and the brain fog and the vestibular problems and a headache that lasts 40 hours straight, you forget to drink water, you lose track of time, and it just keeps going. That doesn't say it is hopeless, like in the film. But if you saw one of my earlier videos, as I used to wear the cowl in my 20s when I would have their violent headache or like PTSD symptoms. I would put the cannula on. I would put a gel tab ice pack on underneath it, and it would calm me down. It's not easy to wear in public. I only wore it once in public, and it was awful because it sweated underneath it. But for Halloween, when the other film came out, this fit my head a lot easier, as you can imagine, and it looked a lot better for it in terms of a Halloween costume. So you'll notice he said root cause a lot when really he was describing triggers and the components that are creating the cascade for the migraine attack. And he also pointed out magnesium deficiency, which is interesting because it's kind of missing the whole picture, which is that magnesium is important as a neurotransmitter regulator for the brain. So all migraineurs are advised to take a magnesium supplement. And the actual type is kind of important. In the migraine support group I was in, someone got a migraine from taking magnesium, and we always asked them, what type did you take? And I was initially advised to take magnesium oxide, and then my most recent neurologist told me to take magnesium glycinate, and explained that if I ever get an infusion, it can only come in the form of magnesium sulfate. But it all plays a role, not so much in deficiency, so that a migraineur needs more of it to regulate the neurotransmitters, because the central problem is going on in the brain. And that now I'm going to go into the actual videos of the migraine specialist neurologist. So this next video is going to be from the headache specialist at the Mayo Clinic. So the Mayo Clinic has two branches. The one in Rochester, Minnesota, which is the one I went to when I was a teenager. They have a second branch in Scottsdale, Arizona, which I went to when just as I turned 20. I only went there once. And their main headaches specialists are there in Arizona, and that's what you're going to listen to.
Migraines are more than just headaches. They're pre-headaches, post-headaches, sensitivities, nausea, fatigue, and can even bring on food cravings. But most of all, they are painful and frustrating for those who suffer from them. For years, they were misunderstood, but now we know it comes down to two main things: your genes and your brain. To really understand why migraines are so much more than headaches, first we have to know what headaches are.
My name is Rashmi Halkar Singh. I am a fellowship-trained, board-certified headache neurologist here at Mayo Clinic. I'm also the Headache Fellowship Program Director here at Mayo Clinic in Arizona. There's actually a huge book called The International Classification of Headache Disorders, which has maybe 300 different diagnoses of different types of headache. So when we say headache, all we mean by that is pain above the neck.
And yes, migraines are pains above the neck, so they are headaches. But again, suffering from a migraine attack is much more than just having a headache.
So migraine is actually a problem of brain dysfunction. It's a genetic disorder that is very common. So by diagnostic criteria, you need to have recurrent headaches, whether they happen infrequently or frequently, lasting 4 to 72 hours without medication. And then in addition to that, the pain has to have at least 2 of the following 4 symptoms.
The pain needs to be moderate or severe in intensity, and more intense on one side of the head, throbs or pulses, and gets worse with activity. But to stay on theme, a migraine is more than just experiencing pain. You also have to have either a sensitivity to light or sound, or nausea. In fact, migraine attacks come in 4 stages, with a painful headache being just one of them.
So when we think about migraine, those would be the 4 phases. Most of what we know has to do with the pain phase.
And what we know is not a lot. It was once thought that migraines were caused by constriction and dilation of the blood vessels that supply blood to the brain.
But we know that's not the case anymore. We know that migraine is actually a problem of brain dysfunction. It originates from the brain itself, and it's a problem of pain processing. And there's a whole host of different components involved in this whole pain processing abnormality. And because of that, there's lots of different genes involved as well. A few genes have been identified, but we're still learning more about this.
So we know that genes are a part of migraines. You can be genetically predisposed to have these painful headaches. And researchers have identified the part of the brain involved with migraines and the lingering pain associated with them.
Really, a lot of our emphasis on migraine has to do with something called the trigeminal nucleus caudalis, which is something in the brainstem that's really important for pain processing. And when a migraine attack occurs, there are what we call trigeminal afferent third nerve endings that also become activated, and they will release CGRP.
CGRP stands for calcitonin gene-related peptide, and when released, helps the pain continue, resulting in the long, drawn-out, painful migraine headache. Now, how this exactly works is still unknown, but the correlation between CGRPs and migraine headaches has actually led to some better treatment options for patients.
For the first time in history, we have preventive treatments designed to treat migraine based on what we know as to what happens in the brain during a migraine attack. And a lot of research has shown us that if you, infuse CGRP in a patient who's susceptible to having migraines, you can trigger a migraine attack. And if you block CGRP, that reduction in CGRP levels correlates with migraine improvement. So based on that information, we've been able to develop some new medications. So, this is a really exciting time in the migraine world.
So you can see that sounds like a description of a completely different disease from the family physicians, and that the root cause here is brain dysfunction that is genetic in origin. And a lot of that is just highlighted by the fact that a lot has changed in the past 25 years in understanding the disease. And I'm going to go straight into the next video, which is the Mayo Clinic again, but in Rochester, Minnesota.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, as you know, headaches are really common. In fact, in the United States, over 15% of adults complain of a severe headache or a migraine. And in fact, migraines affect some 40 million people in the United States.
Ugh. Headaches are twice as common among women than among men, and interestingly, headaches are more common in younger people than those aged 65 and older. Here to talk about headaches, including the latest treatments, is Mayo Clinic neurologist Dr. Beth Robertson. Welcome to the program.
Thank you for inviting me.
So let me ask you about your job. Do you spend all day, every day, seeing people who have headaches?
I do. So I have a background in both nerve and headaches, but I'm interested only in the nerves above the neck. So all day, every day, those are my patients.
And are most of these people do they have migraines or what
The
kind of
strong
headaches?
majority of our patients do have migraines, often very severe migraines that have been hard to treat with their local physicians. So they've had years of difficult to treat headaches before we see them.
You know, before we talk about migraines, tell us about the headaches that most of us get from time to time. The ordinary headache. Do you call them tension headaches? And why do we get
Common
those?
headaches.
Right.
Common headaches.
Right.
Yeah.
So I think, so what most people refer to when they're talking about that ordinary or normal headache would be a tension headache. That's more of a mild, dull, pressure type sensation on both sides of the head, sometimes triggered by stress, sometimes not sleeping enough the night before. And those are often treated with over-the-counter medicines.
Which one's best?
So most patients prefer NSAIDs, non-steroidal anti-inflammatory medicines like ibuprofen or Aleve.
Okay.
But any over-the-counter pain medicine might be helpful.
Acetaminophen's okay too.
That's right.
Whatever works.
That's right. And most of the time, people are able to function with those. They take the medicine, they go about their day, and I never see them in clinic.
When my kids complain about headaches, or even for myself, I just say, drink some water. And that seems to help. Maybe it's just gives you a little bit of time. Do people get headaches because they don't drink enough water?
So dehydration can be a trigger for headaches, often a trigger for migraine headaches. And my son who struggles with migraine, I also tell him to drink some water as a first line. But it's less common to trigger the tension type headache.
I was surprised to learn that there are 40 million Americans. No wonder you're so busy. You're lucky we got you in the studio. 40 million Americans who have migraines, and it's 18% of women and 6% of men. Much more common in women. Any reason for that?
So I want to say, too, for those almost 40 million patients, there's only about 500 headache specialists. So we are quite busy. But as far as why women, so the brain doesn't like change, and migraine brains are particularly vulnerable to changes in sleep, changes in stress, and changes in hormones. So women have those cyclic changes in estrogen around their ovulation and menstrual cycles, and then around pregnancies, and as they get close to menopause, there's this roller coaster over their lives, and that tends to contribute to triggering the headache.
What can you do to fix or to help people who suffer from migraines?
So there are a number of treatment options, and we would divide treatments into acute treatments, so a treatment that you would take at the onset of the headache, and then a treatment that they might take every day to reduce the frequency or the severity of the headaches. Those are preventative medicines.
And you've got some new in both categories, right?
We do. Yeah, it's a very exciting time for migraine. It's really it's nice to be a headache practitioner these days because we have so many new options. Our classic options for the acute treatments have been, as I mentioned, sort of over-the-counter and then non-steroidal anti-inflammatory drugs. And then we've had triptans for many years now that we would use for patients. But more recently, we've had some newer classes. So we have something called a GPANT. This just came out. Ubrogepant is the first one that's been FDA approved. That came out over the holidays. And that is focused on a different pathway. So instead of our classic migraine paths that we're trying to address, now we're focused on something called the CGRP, or calcitonin gene-related peptide molecule.
Yeah,
so
try to remember that, Tracy.
Right. I know it's a long word, but CGRP we've known for decades has been involved in migraine. So we know that during a migraine, CGRP goes up. When you treat the migraine, CGRP comes down. And if you inject CGRP, it will cause a migraine. So we've wanted to figure out how to disrupt that CGRP pathway for quite some time. And the preventatives that we can talk about in a little bit, if you'd like, have been focused on that pathway. But in our acute medicines, this ubrogepant has been designed to block the receptor for CGRP. And it seems like this is able to bring down the headaches in a way similar to the triptans that we've been using for headache in the past, but maybe better tolerated and maybe a little safer for some of our patients. So our triptans were an issue for anybody with a heart attack or stroke because they constrict blood vessels. And this new class, this GPANT class, does not constrict blood vessels.
All right, and the exciting thing also is those 3 new drugs approved in 2018 to prevent migraines. 3 different ones. Do they work?
Yes.
He said that
Not
a
in
little
every,
bit
well,
hesitantly.
you know, because there are commercials that maybe are a bit misleading. No drug works in every patient, but yes, these are also trying to address that same CGRP pathway. So there are 3 what we call monoclonal antibodies that are out. So these are antibodies that are targeting, in 2 of the cases, they're targeting the CGRP protein, and one of them is targeting, again, the receptor, trying to interfere with that pain signal that we think is going on during migraine. And then there's another one that should come out later this year. And so these have been given in a monthly injection form. There's also a potential for an every 3-month injection form. And those, if people are taking them over time, about half of patients will have a 50% reduction in their headaches.
So that's pretty good.
It's pretty good. It's pretty good.
If someone has migraines, they find something that works, then does that efficacy wear away and they have to then move on to something else? Or if you find something that works, are you set?
So both can happen. Some patients do find that magic drug, maybe one that we've already been using for many years, and they do well for years. And then other patients may find that the effectiveness wears off over time and they require something else. And I don't want to mislead, these CGRP medicines are very glamorous, but we do have a lot of other weapons in our arsenal as well that can also help.
Such as?
So there's another new one that I really feel obligated to mention that's in the acute medicines category called lasmiditan. It also came out this year. It's a cousin of the triptans, but also does not constrict blood vessels. So again, it's about finding something that's safer for these patients that have really been untreated for a migraine population. And then we also use Botox injections quite regularly as a preventative with good success.
Counseling, also part of the treatment for patients with migraine.
So counseling like
behavioral therapy.
Behavioral therapy, sure. So many of our patients do have associated anxiety and depression.
Counseling, also part of the treatment for patients with migraine.
So counseling like
behavioral therapy.
Behavioral therapy, sure. So many of our patients do have associated anxiety and depression, and maybe they started anxious and depressed, or maybe just being in pain all day, every day, which many of our patients are, has led to anxiety and depression. And the problem is that feeds back and that can worsen headache over time. So sometimes patients do require additional help addressing that, either with additional medicines for depression or with cognitive behavioral therapy, sometimes stress relieving activities, exercise, meditation, yoga, things to help address that.
Does acupuncture ever work?
Ever? Yes, absolutely. No question.
Yeah, sometimes? Okay.
Always? No.
All right, we don't want to let you go back to your desk and your patients until we talked about cluster headaches, because some people have said that they're even more painful than migraines.
So as far as we know, cluster is the most excruciating pain that we can experience. So from patients who have had both labor and cluster headache, it is worse than labor. It's worse than kidney stones. It is a severe 10 out of 10 pain that's around one eye, associated with watering of the eye, almost like you've cut an onion, just tearing, runny nose. And instead of going to sleep and trying to hide from the light and sound like our migraine patients do, patients with cluster will pace back and forth. They're agitated. They'll bang things against their head. I've had patients where they've asked someone to kick them in their head repeatedly because the pain was so severe. And then abruptly, after 15 minutes to 3 hours, it just comes back down.
Oh my gosh.
But recurs. So it may occur 8 times a day for weeks to months at a time. That's called a cluster cycle. And sometimes those cluster cycles may happen, once or twice a year, but may happen in the same months each year. So as that month approaches, the patients start panicking. Oh my gosh, my cluster cycle is going to come back. I don't know if I'm going to make it through it this time. And I have actually had 2 different patients try and commit suicide.
No. Do you have treatment for these kinds of headaches, I hope?
Yes. So we have a lot of treatments. We are significantly more aggressive with cluster headache, just trying to get them down as fast as possible. So we have acute medicines. The triptans, like we use for migraine, we'll use a faster one. So instead of taking the tablet and waiting for it to go through the food that they ate the day before or that day, we will give them an injection of a triptan, or sometimes a nasal spray, although that's not always fast enough. We will do oxygen.
So I want to point out the most important thing she said there, which is that there are only 500 headache specialists of the United Council of Neurological Subspecialties in the United States, and PubMed says here it's 45 million Americans with migraine, and half of the U.S. states do not have practicing headache specialists, and that makes it harder for all of us. In order to see the neurologist I have now, it was a 9-month waiting list, and from what I understand, that's very common. And the time I get to spend speaking to them is very short. And it compounds because it's, this is still a disease where, the only diagnostic tool is the patient's voice of the patterns and what they're experiencing. And on that note, going to cluster, when I initially showed my headache chart to the neurologist at the Mayo Clinic, was a teenager over 20 years ago, they looked at this and they thought cluster, which was surprising to them because I had been diagnosed with migraines with aura at 7, and that cluster exists within 1% of the population, and the overlap of people who have both is within that 1%, so it's very rare. In my 20s, they were just violent headaches. I would punch the floor, I would punch the wall. There were times in the hospital where I would scream until I lost my voice. And that's not something I would do with a migraine, where I'd just feel incapacitated and just couldn't move. It also explains the extreme pain in my left eye. And my father has cluster. He has the classic symptoms of just always having pain in just his left eye. It's sometimes tearing up. And he was here a week ago, and I saw him sort of sitting down, grabbing his eye, and just he's having a spell, and I had to give him my oxygen. And the next video is on sensitive brain.
Black and white. It's blurry and shadowy, but there are many forces at work trying to change how we think about and deal with this disease.
The brain of a migraineur is exquisitely sensitive. We want to be able to detect stimuli, but we don't want to be overwhelmed by the stimuli which we detect. This gets to the heart of a question about dysfunction in migraineurs that we call a defect in habituation. So if I walk out into the bright sunlight, it's very bright for me initially, but I can adapt. Not only does my eye adapt by constricting the pupil, but my brain adapts to the intense amount of illumination and will stop being overwhelmed in a very short period of time. The brain of a migraineur, however, will continue to be overwhelmed and will not habituate the way a non-migraineur will. And in fact, they will continue to have increasing levels of central stimulation until they reach a critical point. And that critical point is their threshold for triggering of a migraine episode. And I think that most migraineurs do have experience with this phenomena in which they're overwhelmed by some aspect of their physical environment. They attempt to adapt, they cannot. They insist, however, on staying in the environment, but if they insist too far, they can no longer leave the environment and feel better, because a physiologic cascade of the migraine attack has begun and now has to run its course. When a patient has migraine, their brain, which is already sensitive, becomes even more sensitive. If I have peripheral pain, maybe back pain, and my pain level is only a 2 or a 3 out of 10, when I'm having a migraine episode, my pain level may rise to 5 or 6 out of 10. In that case, I have a peripheral problem that's real in my back, but my perception of it is increased because my brain is much more sensitive during the migraine episode. There are three main categories of triggers for migraine. Those are physiologic triggers, environmental triggers, and food triggers. A physiologic trigger, examples of physiologic triggers are hormones, allergy, dehydration, hunger, sleep or lack of sleep. For some people, oversleeping on the weekend is just a death sentence in terms of migraine. And we know that each individual, exercise is a common physiologic trigger. Odors, so now we're going to get into other sorts of environmental triggers. So patients with migraine have a sensitive brain, and the sensitive brain is something that is sensitive to any sort of excess sensory stimulation. So if you follow down your senses, any excessive pain, touch, visual stimulation, sound, motion, smells can provoke a migraine attack for very many migraineurs. Food triggers are a very important part of migraine management because many patients wish to solve their problems without taking medications. Typically, patients who have dizziness related to migraine do not have symptoms that will respond to medications to eliminate symptoms when they are occurring. They therefore have to prevent their symptoms by taking medications that elevate the threshold for triggering of migraine, or in other words, stabilize the head against the possibility of abnormal migraine activity. Food triggers have been recognized for hundreds of years as aggravating factors that can precipitate migraine attacks. Scientifically, they are difficult to identify and prove because most food triggers are not very strong. They are only partial triggers, and it is only when an accumulation of partial triggers puts a patient over their personal migraine threshold that their symptoms may emerge. So a food which is a partial trigger for me may be something that I eat relatively frequently, but only occasionally is it the factor that puts my migraine symptom accumulation over my threshold and cause symptoms. Well, I think there is the chicken and the egg, and there are feedback loops in migraine, and we try to interrupt them. Hunger is certainly a common trigger that is a recognized physiologic trigger of migraine. But beyond that, there are specific categories of food triggers. Some foods have very complex chemistries. These are the products of aging and fermentation, have chemical soups which find their way into the central nervous system and alter function in a way that the sensitive brain of a migraineur may be stimulated by. There are other categories of food triggers in which resemble central neurotransmitters directly, like caffeine, like the xanthines in chocolate, like tyramine in aged cheeses, and even glutamate, something which has been studied and talked about. And some people believe strongly that it is a trigger, some people strongly that it is not a trigger, but it is glutamate is a central nervous system stimulatory neurotransmitter. There is another category of food triggers which we call mystery foods. We just don't know the chemical nature or a possible chemical nature of the irritant in foods like bananas and peanuts, yet they are unquestionably unequivocal triggers for many patients. When a patient has intermittency in their headache pattern, now lots of other good things happen, especially in the area of triggers. If I'm living above my threshold and I have constant migraine activity, how can I tell what my trigger is?
So he touches on an important point, which is that once you get chronic migraine, it becomes daily. It becomes harder to understand what the triggers are. And it's almost like analyzing your disease in reverse, where when you get a period of stability, it's like you're trying to figure out what caused the stability rather than when you're in pain. What was the trigger that caused the pain? And before you can figure that out, the pain returns. And because you're trapped in a vicious cycle, and there are enough things that are causing the pain that it's out of control anyways. So many years ago, I came close to donating my brain for research. And so the next videos are going to be on the brain itself and the imaging.
This is a 48-year-old female who complains of migraine headaches for many, many years. They were worse lately, so she wanted to get another MRI. She's had MRIs in the past that describe white matter lesions, typical for migraines. And on this examination, again, she shows white matter lesions that are pretty classic, so I want to show you just a straightforward example of white matter lesions that may be related to migraines that would fit her clinical picture. So this is a sagittal view. This is the top, front, back. The neck is down this direction. And we see in the brain here lots of little specks scattered around. And these specks are not in the gray matter. The gray matter is around the rim. They're in the white matter, which is that dark uniform part of the brain. So numerous little specks all scattered throughout the white matter. And a lot of them are peripheral. Some of them are more in the middle, central portion. You can see here like a cluster of them in the frontal lobe on the right-hand side here. Now we're going to look at the same little white matter specks on an axial image. So on the axial image, we can see the eyes in the front here. We can see the right side here, left side here. And as we go up, 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 these are the frontal regions in here. So we're going to look at the frontal lobes. Typically, migraine headaches cause little tiny scattered white matter lesions like this. And they're typically in the frontal lobes. They can be in the parietal and temporal lobes as well, occipital lobes, but most of them tend to be anterior and symmetric. A lot of times we have patients who have migraine headaches clinically, and they have an absolutely normal number of the brain, or they have one or two little tiny specks. Those are difficult.
So let's define an actual migraine. A migraine is a complex neurological disorder that can be divided into 4 different phases. And we're going to talk about each one of these phases as they apply to a migraine. The first phase is called the premonitory phase. This can start up to 72 hours before the actual headache, and people will experience symptoms like fatigue, photophobia, which is light sensitivity, irritability, sometimes depression. They can also notice that they might yawn more, also have food cravings, and even stiffness in certain muscles, especially in the neck. And so the next question might be, what is actually starting this phase or causing this phase? And they believe it's an actual alteration in homeostasis. And if you talk about homeostasis, or keeping the body in balance and equilibrium, you have to talk about this structure called the hypothalamus. So the hypothalamus is in the central core of the brain. And you can see I'm tracing it with the probe here. Now, some other structures you may have heard about are something like this, the pituitary gland, which is below the hypothalamus. And over here, you can see this expansion referred to as the brainstem. If you go follow it down, that becomes the spinal cord. But again, we're coming up to this structure in the central core known as the hypothalamus. And this thing, again, gets involved in homeostasis. So how does it get involved in homeostasis? Well, one, it's the principal autonomic center of the brain. And so therefore, it takes care of certain parts of the nervous system that you don't have to think about. Also gets involved in regulating and releasing hormones. This is probably why women are a little bit more affected with migraines than men. Also gets involved in regulating certain behaviors, also food cravings, so thirst and hunger mechanisms, and even gets involved in regulating body temperature. So if we kind of just take a step back and we look at, okay, this is what the hypothalamus is involved in, and we compare that to the premonitory symptoms that we talked about, things like fatigue, the food cravings, you can see that relationship between the symptoms and what the hypothalamus actually does. So are there things that a person with a migraine can do that influences if they get a migraine or not, or possibly triggers a migraine? And the answer is yes. The data has shown that people with migraines, their brain tends to be a little bit more sensitive to certain environmental stimuli. And they have gathered a whole bunch of data on certain environmental stimuli that are potential migraine triggers. And this can be quite the long list, so buckle up for this. They think that some of these triggers are emotional stress, hormones, not eating, weather, sleep disturbances, even odors, neck pain, alcohol, bright lights, smoke, certain types of foods, even exercise, and even sexual activity.
This is where communicating my health gets a little awkward, but it's still important because that's what I do. The women I've slept with did not know I was disabled, with only like one or two exceptions. But I mean, the one I was in a relationship with, she found out, you know, during sex, like afterwards, because I had to stop. But just in general, I highlighted, you know, it is exercise in its own way. And what he says about stress is that you have to remember that positive stress, in all senses, is a trigger. It's not just negative stress, and it's not just emotional stress, it's positive stress as well. So being really excited for something in general, even if you don't actually do anything, even if you're just looking forward to something, that's always been a trigger throughout my whole life, even as a child. So looking forward to something can be a trigger. Also, in terms of dating, there's always usually alcohol involved. And either if one of the common things that would happen is that I'd be dating a woman and she'd have drank wine, where it's a trigger for me, but, you know, it's on her lips and it would be enough.
The next phase of a migraine is the aura phase.
The pathophysiology of migraine aura is very interesting, because if you look at all the migraineurs in the world, approximately 75 to 80% of, at least in the US, 30 million people do not have an aura. And only 15 to 20% do. Now, that's not to say that if you have migraine without aura, in your lifetime you may have one or two auras. However, migraine with aura patients typically have one all the time, but sometimes they'll get an aura without a headache. The aura, it's basically secondary to what Liao called in 1944 the cortical spreading depression. And what that means is that you have oligemia, you have blood flow decreases starting at the back of the brain, and it moves forward. And what's very fascinating is, just like a neuropathy, which, for instance, let's say it's a diabetic peripheral neuropathy, stocking glove, so that glove can go from here and involve all the hand, which means it's involving parts of 5, or 4 to 5 different dermatomes. And with this spreading depression, cortical spreading depression, the oligemia, the decreased blood flow, can be found in different hematological areas. In other words, the posterior circulation, the middle cerebral circulation, it just moves forward. So just like you see here with multiple dermatomes, you can see that with multiple areas of hematological activity. What's really important for people to know, because everybody focuses on the fact that the migrainous aura is visual in nature, is that's true to an extent, but there's an extraordinary number of auras that are not visual, that are sensory, that are cognitive, things that one would not expect. For instance, an aura I've seen probably a couple of dozen times. It's called a Chiaro oral migraine, and what happens is patients will develop numbness in their hand and their fingers, and it will go up their arm to about the elbow, at which point it will jump to the ipsilateral side of the mouth. And what does that mean? Well, that means if you look at the homunculus in the motor strip in the brain, the thumb and fingers is right next to the corner of the mouth. So this aura really goes right where you expect it to. And that's a sensory aura, and it's scary as hell to people. that's the purpose, really, of the title, Tea Party in Hell, because these people are damned. They have things that occur to them that they have no control over, that can occur at any time, that can leave them not only with a severe headache, but before that, in an extremely frightening situation, particularly if their aura changes, which is not unusual. You can have, I mentioned, cognitive auras. You can also have aphasias, receptive or expressive aphasias, the inability to talk or understand what's being said as a migraine aura. Transient global amnesia used to be thought to be secondary to epileptic discharges in both temporal lobes, but now we know it's really a migraine aura. And I had a patient, probably the most famous patient I can remember with that, who drove from Chicago to Las Vegas and lost really big, including his house, his mortgage, and everything else, and then was driving back to Chicago. He stopped to get gas, went in to get some coffee, and woke up. Now, you wouldn't have known he was having an aura, but this was a prolonged migraine aura, which is a whole nother issue because migraine aura typically lasts 60 minutes at the most. But that's what happened to this guy. And everybody's sitting there wanting to treat him with anti-epileptics. And this was before the FDA had approved either Depakote or topiramate for migraine aura. The other issue is that you can have more than one aura. You can actually have a visual aura that can last anywhere from 5 to 15 to 60 minutes, and then have that sensory aura I was telling you about, which may last 20 minutes to a half hour, and then have a third aura, and then get your headache. So there's also, in some patients, they'll have a cognitive aura and might be 2 to 3 hours before they get the headache. First, the clinician's got to understand what the difference is, what's going on. First time a patient has a neurological aura, particularly if there's no history of migraine, that calls for a full court press in the emergency room. That's a full neurological evaluation. Okay, MRI, CAT scan. Now understand that for the typical headache patient, they should not need MRIs, CAT scans, or any of these tests. It's a clinical diagnosis. But if you know that there is a history of migraine, that sort of makes it a lot easier to determine, oh, okay, they got a history, it's family history, not a problem, unless there's something significant. For instance, the red flags for headache is first called a thunderclap headache. The worst headache of your life, put you on the ground. Typically that may be associated with an aneurysm that breaks in the brain. Nothing to do with migraine, but you're going to get one hell of a headache. If one aura lasts longer than 60 minutes, problem. Okay? If a patient has, for the first time, what looks like a hemiplegic migraine. Now, most hemiplegic migraineurs are, there are genetic differences. We know that they have differences in the genetics and the chromosomal aspects, but sometimes you'll see it as a formed frust. The first time a patient has an aura, didn't even know they had migraine, they may show up in the ER with a hemiplegia, which means, as far as anybody else should be concerned, that's a stroke until proven otherwise, or a TIA if it doesn't get better within an hour or so. So it's more than just, oh, yeah, that's a migraine. But if it's a thunderclap headache, if it's a significant neurological problem that the patient's never had before, if it's a typical aura or atypical that lasts longer than an hour, one of the things I'll be talking about is the Alice in Wonderland syndrome. What happens in this Alice in Wonderland syndrome, unlike other auras, is the patients lose the ability to perceive things correctly. The eyes can look at things, but there's a a problem, a disconnect in the brain, where you can get micropsia, everything looks small. You can get macropsia, everything looks big. Okay, you can get perceptual displacement. You don't know where your arm or your leg is. Okay, things like that occur, and the differential diagnosis is not just migraine. Epstein-Barr virus, encephalopathy can cause it. Other types of issues can cause the Alice in Wonderland syndrome, including brain tumor. So it's not as easy as you think. You know, when we first started years and years ago, before we knew more about this, it was, it's a migraine or get a headache, you know, you'll be okay. Then we, developed the triptans, thank God, and these other medications. But then we had to learn how to use them correctly. Now, the last point I'll make is that some people believe, and what we've seen, is that the migraine does not have to, it usually does not occur when the blood vessels get large. It starts when one of two things are happening, when you have that oligemia, which means decreased blood flow. And secondly, it could not be that. It could be of a type of cortical wave where the neurons are putting out glutamate, other excitatory amino acids that just create a rolling thunder, if you will, that just potentiates this visual problem or sensory problem or cognitive problem.
So what is responsible for the aura phase? The going theory or going hypothesis is there's this thing called cortical spreading depression. Cortical refers to cortex. And in this case, we're going to use the brain to help us with this. So if you orient yourself to the brain, what I'm tracing here is called the cerebrum. And the outside surface of the cerebrum is referred to as the cerebral cortex. And that can kind of give us the idea of cortical in the cortical spreading depression. So we're referring to the outside surface of the cerebrum called the cerebral cortex. Now the spreading depression, what do they mean by that? Well, they believe that there is this depression of neurons. In other words, neurons depolarizing, which is neurons firing off, that spreads throughout the cerebral cortex. And think of it almost like a drop of water in a pond and that ripple effect. And because of this spreading depression, the neurons tend to stay depolarized, which is a neuron fired off before it recharges or repolarizes, longer than it normally would. And they believe this is responsible for the aura symptoms that we just previously mentioned. Now, some people might say, okay, well, what about the people who don't get the aura? And the answer is they think it may be occurring, this cortical spreading depression that is, in areas of the brain that aren't under conscious awareness. And so people may still be getting this cortical spreading depression who don't have the aura, they just might not be noticing it. Finally, we're on to the third stage of a migraine, which is the actual headache phase. Now, this is characterized by a pulsatile throbbing characteristic that tends to be unilateral. Some patients will get it on both sides of the head and even on the back of the head, but most commonly it's one-sided. Now, a lot of patients will also experience nausea, vomiting, photophobia, which is light sensitivity, phonophobia, sound sensitivity, and even some people will get sensitive to smells. Few people will get this thing called cutaneous allodynia, which is sensitivity to touch, like the skin just gets hypersensitized, and just even touching a certain area of the skin will cause pain. Now, what is the cause of this? Now, we got to do our step-by-step approach, and the premonitory phase and that cortical spreading depression is thought to enhance or activate this trigeminal vascular system. Now, some of you may have heard of this thing called the trigeminal nerve, and this nerve gets activated in this trigeminal vascular system, and this is going to be the cause of the pain. Now, the trigeminal nerve, why is it called the trigeminal nerve? Well, three. Tri means three. There's three branches that branch out of the skull, coming off the brainstem, and flare out onto the face. So, one part of the branch goes to the forehead and around the eye, and that's called the ophthalmic division of the trigeminal nerve. The other around the cheek is called the maxillary division, and the third is called the mandibular division. This nerve is sometimes nicknamed the great sensory nerve of the face, because everywhere you touch on your face is brought into the brain through that trigeminal nerve. Now, that's important for certain locations of the migraine, but there's some internal structures that we actually have to talk about that play a key role in the pain of a migraine. Okay, so the internal structure that we want to show that the trigeminal nerve also controls is this stuff called the dura mater, which I'm pinching here. The dura is a connective tissue structure that surrounds the brain, and it does have sensation, and specifically it can sense pain. And when the trigeminal nerve gets activated during a migraine, it can sensitize the nociceptors in this tissue, which are pain receptors. And that signal will then come in to the brain and actually detect pain here. Before we go into more detail, I just want to show you how this is wrapped together. If I remove the skull here, you can see how the dura surrounds the outside of the brain as I pull the brain out of here. So now that we know the origin of the pain, coming in from the dura through the trigeminal nerve into the brain, we have to kind of describe, okay, well, why do I feel pain around the eye or the forehead, or in some people in the back of the head, when the stimulus is essentially coming from inside on that tissue called the dura? Well, that's a story of referred pain. And to describe referred pain, we have to describe neurons converging in similar places of the brain. So for example, if I have a sensory neuron on my forehead and a neuron from the dura going into the same area of the brain and converging on a similar nucleus inside the brain, that sometimes tricks the brain into thinking, oh, the pain's coming from here, even though the stimulus came from a different structure. And because those converge on the same area, that can give you areas of pain, say in the forehead or the back of the head, on these converging neurons. And that gives you an idea of why you can have different locations of pain from the migraine. So finally, we're to the last phase of a migraine. The last phase of a migraine is called the post-drome phase. And that is essentially lingering symptoms from the migraine. Now, migraines can be debilitating partly because it just hurts to do anything like turn your head, sneeze, cough, and things of that nature. And the next day after a migraine, a lot of people will realize, oh, I turned and I had pain. I sneezed, I had pain in that same area. And the reason for that is something called sensitization. The nerve that we talked about, the trigeminal nerve, in those tissues, those sensory fibers or nociceptors essentially get sensitized to stimuli that normally wouldn't cause pain. And again, that's why you turn your head and it can hurt, or you sneeze and it can hurt. Now that typically goes away over the next day or so, but that's why you get this fourth and final phase of a migraine called the post-drome.
So I decided to splice a number of videos there together and complemented each other, where I thought some videos explained things better than the cadaver guy. The next one is on comorbidities, and it's by the Michigan Headache Clinic. I never went there, but I met some patients in Chicago who had gone there, but it was outside of my network.
First of migraine here, and we thought we'd bring in the old 1941 horror movie, because a lot of us feel, I mean, I too am a migraine sufferer, and now, of course, as we all know, too, there's more than 38, some people say 36 million Americans. If you were to walk down the street and knock on doors, 1 out of 4 houses would have at least one migraine person living in it. And we're looking at 10% of school-age kids, and daily headaches, looking at 14 million people at least that we know of have daily attacks. So it's a pretty big deal. And the way we approach migraine these days is to look at the migraine disorder itself, but also to look at the comorbidities, which are the other conditions which go along with migraine, which interfere with making people better. Sometimes the only difference between a good treatment plan and a bad treatment plan is the attention to all the details that relate to the migraine, because if we don't fix everything that touches migraine, we don't get the migraine under control. Now here's what I said I would explain is what comorbidity is. And it's any medical condition that exists simultaneously but independently with another condition. Or it's a condition that causes or is caused by another condition. In other words, when 2 things occur more commonly than the general population, we consider them comorbidities. And again, in migraine, a lot of things happen more commonly in migraine people than they do in the general population. Like in migraine, certain people with migraine have increased vascular risk factors like high cholesterol, high blood pressure. And such people end up with vascular disease and stroke, which is very important because sometimes migraine symptoms imitate a stroke, but it's not a stroke. And sometimes the medicines we use for migraine are not safe in stroke patients. So this is a very important point. Now, from the psychiatric side, this is a really big one. In the migraine world, anxiety and depression occur more commonly than they do in the regular general population. And in the population of people in the psychiatry office that have depression and anxiety, they have a higher incidence of migraine than general population does. So these are called bidirectional comorbidities. In other words, if you have one of these conditions, you have a greater chance of having the other. Now, the common chronic pain disorders also are more common in migraine people, like irritable bowel and fibromyalgia and osteoarthritis. And asthma is a very common thing in the migraine population. And this is important to us for a lot of reasons, especially that some of the medicines we use for migraine cannot be used in asthma patients, like beta blockers, especially propranolol, Inderal. can cause an asthma attack. So it's very important that the person treating the migraine patient is aware of this so they don't provoke problems. Now, epilepsy is a little bit more common in the migraine population, but not to a large degree. But the really big one is the sleep disorders. It's very common in the migraine population to have an increased amount of insomnia, either getting to sleep or staying asleep difficulties. And of course, this is a big problem because people that don't sleep well end up with more migraines. Again, your doctor needs to be aware of your medical history in great detail, because 18% of people with migraine actually can't use the triptan drugs. The triptans are the drugs like sumatriptan, rizatriptan, like Imitrex, Maxalt, Zomig, all of that. There are 7 drugs in that family. The triptan drugs are contraindicated in people with heart disease or stroke. People with leg pain that gets worse the further they walk. It's called claudication. It's due to arterial disease. Angina, chest pain, all these things cannot be used in patients with migraine. If someone has had a stroke or a heart attack, or might have a stroke or a heart attack because of their other symptoms, we can't use these triptan drugs, which normally are wonderful in migraine. With aura, in other words, if you have a migraine with a warning ahead of time, be it visual or sensory, people who have an aura like paralysis or double vision, these are all aura-type associated symptoms. They are more likely to have stroke than other people are. Now, if you have migraine without an aura, just plain old migraine that doesn't have anything along with it, except maybe nausea, vomiting, light and sound sensitivity, if you have a regular migraine without the aura, the current data shows that you're not at a greater risk for stroke. So this is reassuring. Now, the frequency of migraine, the WHO, which is the World Health Organization, they find a higher incidence of migraine in people who have a higher incidence of ischemic stroke. In other words, when people have a blood clot, that gives them a stroke. Now, in young women, a big study was done showing only women who have visual aura, like I just said, over age 12, are the ones who have double the risk of stroke. So, again, this is 2 times the risk of a very small number, so don't get too nervous when you hear this. It's the risk of stroke is actually a small number anyway, so this is double the risk of a small number, but it means you need to be careful. Now, I'll skip this frequency and stroke thing again. Let me jump over to depression. A lot of work was done by Breslau, and showing how major depression increases the risk for migraine, and people who have badly controlled migraine actually have a higher incidence for depression. And it makes sense in many ways. Depression affects many functions in the brain, and if you're at risk for migraine and you're not having a very well-controlled depression, you're not being treated, you may have a higher incidence of those migraines. And certainly chronic pain increases the depressive symptoms in people who have depression. And in other kinds of headache, like cluster and other types of headache, this is not true. It's migraine that seems to associate with the depression. Now remember, there are about 200 different headache types in the classification system of the American or International Headache Society. 44 of those are migraine, and those are the people who seem to be connected with the depression. And it doesn't have to happen at the same time of your life either. If you're the person with the biology of depression and the biology of migraine, these may occur together or at different times in your life. Now, anxiety is another big one in migraine people. And it's more common in people who have post-traumatic stress disorder, PTSD. And, we check for it in all of our new patients. We check for physical or sexual abuse histories and PTSD symptoms. And it's unfortunately very common in our population to find this. And these are people who have anxiety as well. Now, generalized anxiety disorder or panic disorder is more common in the migraine people. And this is important because when we treat migraine, there are ways we can prevent migraine that also benefit anxiety and depression. So this is why it's so important for us to understand whether a person has these 2 conditions. Of interest also is the OCD side of things. Now, again, I can say this because I'm a migraine person too. But those of us with migraine, most of us are control freaks. We have to control things around us. We're just not happy unless we're in control of a situation. We're attracted to careers like teaching and medicine and places where we can make a difference in some way in our view of the universe. And so the OCD side of it. Now, migraine people notice detail more than other people do. When you are using a medicine for epilepsy and also for migraine, like I don't know, Depakote or something. The seizure patients, they don't seem to notice half the side effects that migraine people notice on the same dose. We are like very detailed creatures, and that's why I bring this up. Now, sleep disorders is another one I wanted to talk about in detail. Is a very common problem in migraine people. Over half the people with migraine report difficulty in initiating or maintaining sleep, at least occasionally. And we're talking about how many days, maybe every day per week, maybe half the days of the week. It's very common. And our strategy in our clinic, and probably most other clinics, in treating headache disorders is to find ways to normalize the sleep-wake cycle. Because disrupted sleep can be, definitely can get in our way when we're trying to treat. And migraines can be triggered. About 50% of people will notice that poor sleep the night before can trigger a migraine the next day. By the same token, you can have a migraine in the middle of the night during sleep that will wake you up, and the intensity of the pain will sometimes, crank out enough adrenaline that you will stay awake for a while. So these two go hand in hand. It's very important. Now, sleep complaints occur with greater frequency among the chronic headache people. People that have the occasional migraine once a month or something are probably less likely to have sleep problems than people who have frequent migraines, like more than 15 days a month. That makes it chronic. Now, an irony, migraine people have problems with sleep and wakefulness, like I said. The disorders of sleep and wakefulness can worsen a migraine. Now, headache awakening from sleep were reported by 71% of people. I mean, most of us have at some point or other been awakened in the middle of sleep by a migraine. And most of us will try to sleep off a migraine. But the irony is we can't always get to sleep if we're in that much pain.
So unfortunately, some of this information does repeat, but that he went through a lot that nobody else really, I thought, explained as well as him. And with the comorbidities and the feedback loops indicative in that. And he's the only one to really acknowledge the sleep problem, which is that the two of my headaches there at the bottom are excessive sleep headache and lack of sleep headache. And the other headaches are the ones that keep me awake. And it just creates a feedback loop of disruption. Moving on, the next video is on cutaneous allodynia, which was something mentioned earlier, but it's by someone I'm familiar with. This is Dr. David Dodick. I met him in 2005 at Scottsdale, Arizona, at the Mayo Clinic there branch. He is the neurologist that trains other neurologists. Essentially, he is one of the world's foremost authorities on all this. So he does the clinical research, and he did the research behind the CGRP inhibitors. And he does conferences on how to advise neurologists on how to use them. So he's the past president of the American Headache Society and past chair of the American Migraine Foundation. And personally, when I met him, he was one of the best communicators I'd ever met.
MAST was a huge study, involved over 15,000 people in the United States. What we were looking for was the factors that were associated with something called allodynia. Now, what is allodynia? Think of sunburned skin. When you have a sunburn on your skin, it hurts, even when you don't touch it. When you touch it, which shouldn't be painful, it's painful. And when you squeeze it, it really hurts more than it should. So allodynia is really when touch becomes painful. So what we set out to do was, in these 15,000 plus people with migraine, we wanted to know what factors are associated with allodynia. What we found was basically three things. The more severe the attacks and the more frequent the attacks, the more likely it is for people to have allodynia. When people overuse acute medicines, whether it's over-the-counter or prescription medicines, they're more likely to have allodynia. And by overuse, I mean using it 10 or more times per month. So when you take something for pain 10 or more times per month, that's what we refer to as overuse. So people who overuse are more likely to have allodynia with their attacks. And finally, and most potently, depression and anxiety. People who have depression and anxiety are 83% more likely to have allodynia. So what does that mean for doctors? It means that we need to pay attention to those people who are overusing acute treatments. It means that we need to pay attention to those people who have more severe and more frequent attacks and get them on prevention. And it means that we have to start looking for depression and anxiety in our patients, not just addressing the headache or migraine, and treating it and managing that. Because if we do that, we'll reduce the likelihood that they'll have allodynia with their attacks, and we'll reduce the likelihood that they'll get worse over time. So that's what this particular part of the MAST study looked at, and that's why I think it's important. So, the presence of allodynia indicates both the severity of the attack and increases the likelihood that not only will the attack progress and persist, but that more frequent attacks will occur. So someone who has just a few attacks per month, if they're associated with allodynia, they're much more likely to develop chronic migraine over time. If treatments don't work for an acute attack, those patients are much more likely to progress. So allodynia itself is both a marker for non-response to acute treatment and progression over time, and non-response to acute treatment in and of itself, regardless of whether allodynia is present, is also a marker for progression over time. So allodynia is not good. And allodynia is often not actually searched for by doctors in practice. People don't ask the question. Sometimes patients volunteer, but many times they don't, because they think, why would the doctor want to know that, number one? And maybe they think I'm just a complainer. Like I'm saying that, it sounds crazy that my glasses hurt on the bridge of my nose, or I don't like earrings or necklaces on, or I can't stand hot water hitting my head, or I can't stand shampooing, combing, or brushing my hair. So we need to learn about allodynia, why some patients develop allodynia and why some patients don't. Why is it that some people can have attacks, even frequent attacks, and never have allodynia? I mean, what is it about them that makes them different from someone who has allodynia with every single attack? It may be genetic. It may be something else that we're not aware of. I talked about the fact that depression and anxiety and the overuse of acute medicines and frequent attacks are associated, but that doesn't mean it causes it. You see what I mean? There's a difference between an association and causation. So we really need to know what causes allodynia, either externally in the environment or internally in our genes. And once we understand better what causes allodynia, then we'll be able to target it and treat it better. So right now, what the MAST study showed is what's associated with it, and that's helpful. But this was what we call a cross-sectional survey, right? At a point in time, we're asking you a whole bunch of questions and figuring out whether you have allodynia and what's associated with it. We're not really tracking you long-term over time. And we didn't get to you long ago to know why it is that you developed allodynia. So there's a difference between association and causation, and we really need to know what causes it. To really, so-called getting at the root cause will allow us to fix the problem.
All right, so this is a difficult story. Because I didn't know this at the time, that this symptom, I didn't know the name for it when I had severe events. When I was in the hospital at one point, it was one occasion, I think it was 2011. It was one of the only times I was in the ER where other patients requested I be seen because I was in visibly so much pain in the lobby. When they eventually got me back, it was a Friday in the hospital, so it took hours. And eventually they didn't give me the right protocol. They gave me a steroid infusion of Solumedrol, and so my body was just amped with energy. And then there's always a mess up. Then there's a shift change, and I'm dealing with a whole different group of doctors, and the pain hasn't come down, and because they gave me the wrong thing. But at the end of it, after about 9 hours, I had a nurse sort of like, because at some point I admitted I was suicidal. I was ready to donate my brain for research. So I was no longer a neurological patient in their mind in any sense. I was being admitted to a psychiatric ward. So that was difficult because then they immediately just said, okay, we got to take your IV out. And this nurse came up and she just started grabbing my arm. And I kept screaming at her, "Don't touch me, don't touch me." And her hands just felt like fire, and I was just couldn't handle it, and I pushed her away. And then I just ripped the IV out of my arm myself. And then, of course, it starts bleeding, so she starts grabbing me again and starts trying to clot the blood, and I keep pushing her away to get, and it didn't bleed much. All I had to do was just bend my elbow, but she was really upset by that. And the next thing I know, she walks into the room with a new needle and a bunch of cops, and they pinned me down, all of them, and with Haldol, and my body doesn't react well to that, and I started just foaming at the mouth and sort of vomiting out this sort of orange foam. And this was all sort of started by the fact that I just could not be touched. I just couldn't tolerate it. So YouTube is also a time machine because it's been around for so long. So I'm going to play a much older video, and then I'm going to explain why I'm playing that particular video.
In particular, the clinical progression of migraine depends first on frequency of headache experience and the individual's reaction to that headache, so that there's a biologic phenomena, and yes, there is a limbic phenomena, the memory system and the implications of pain, which tie into basically our cultural beliefs. So it is a complex combination of biology, the body, and the mind, so that for the patient who is most difficult in one's practice, one rarely gets a really satisfactory response by just manipulating the biology through drug therapy, rarely through needle therapy. But you really have to understand that individual, who they are, and what they want, and work with them to change behaviors and thought patterns. So it's really, in a sense, getting to know what their concerns are beyond just get my headache better. What is their life all about? And that I call the art of medicine. So my talk was a little bit about science and a lot about employing the art of medicine, which is a lot about the power a practitioner has in how they communicate with an individual. Yeah, the cyclone of headache is sort of a way for the practitioner to realize where they're at if they really review the issues within the cyclone. If you can get a patient early enough in the process, when they have 4 or 5 headache days, they're not in the cyclone. But as they become anxious about their next headache, as they have a memory about the last headache they suffered, as they take a drug a little quicker, or maybe even preemptively take a medicine, which we may encourage them to do, as they incorporate other things that happen in their life. They're a little over scheduled. They aren't having enough time to eat. You start to get into the cyclone issues, and those are sleep disturbances, not enough time spent exercising, a little overuse of medications, acute, trouble tolerating the preventatives. You start to see within this framework anxiety and mood, which they of course attribute to the pain and not an independent phenomena in any way. And these all just become worse and worse, so you spiral, in this case, down in disability, and often spiral up in the use of acute therapies. And it's just a way of trying to get practitioners to realize the complexity of the disorder and that there's not one simple solution here. Well, there's a controversy between patent foraminal valley, PFO, and stroke, and there's a controversy between PFO and migraine. Yeah, we all have a PFO in utero. We all do. Roughly 20% of us have a PFO in adulthood. Somewhere between 20 and 25% of us have this patent foraminal valley if we're a migrainer without aura, and somewhere between 40 and 49% based on studies if you're a migraineur with aura. So the particular group of interest is migraineurs with aura who are at increased risk of stroke, especially under age 45, and could their whole disorder in some way be influenced by this hole in their heart? And the answer right now is unclear, and it's controversial about even looking for it. So I encourage anyone who makes this connection that they really enter this individual into one of the research studies. There's at least 3 going on right now. And don't rush off to do any PFO closure, because, in fact, we may learn that it's not the right thing to do.
So he has a lot of good information there about the cascade and the Cyclone effect and the interconnectedness of the components of the nervous system and how they sort of interact and feed into each other. But that's not why I chose him. He was my neurologist when I was a teenager, and the controversy he's talking about with the PFO closure is me, because in 2005, when I was 20, I was the first person in the United States to have the hole closed specifically for migraines. And the way it unfolded was that there was anecdotal evidence that people who were having it closed for other reasons were reporting improvement in migraines. And we looked into this, and my grandfather's a physician. He referred me to his cardiologist. My cardiologist has looked at it, and my heart, sure enough, I have the hole. And not only do that, I have blood passing through it, which is a significant component of it, because that is the hypothesis of how it affected the migraines, which is that the blood is bypassing the lungs, so it's unoxygenated, and the first place that goes is straight up into the head. So that was the idea of how it was creating the cascade, and that's how it's connected. The way it works is like going through a humanitarian exemption with the FDA. I didn't think I was going to get cleared for it, for one. I didn't think they would actually clear me, because they rejected a lot of other patients. But I was the youngest, so they cleared me, because I had it every day for 5 years, and I was diagnosed at 7. So the other reason I had no regrets about it is that it significantly decreased the risk of stroke. And stroke existed on both sides of my family, and the losses were devastating and in recent memory at that time. Even on the side of my family that doesn't have migraines. So, but what I do have regrets about it is this. So my father used to work at the St. Paul Pioneer Press, and it was well known through him that his son suffered with migraines. So when one of the journalists was reporting on this, because the actual device that was going into the heart, he called my father to just ask him what he knew about it, and then he learned, well, that I just, by coincidence, I had it just put in my heart like 2 months ago. So then he asked me if I'd speak to me, so then I spoke to him, and then I got my name in the paper, and they did a story on me, and I sort of it was only a few months after surgery, and I was like, yeah, I've been a little better. But spring came, and the normal migraines returned. But that is where the controversy comes from, because I don't know who else got the surgery for migraines and how their lives got affected or improved or not. I don't know. But this next video is by another neurologist about it.
So patent foramen ovale is a residual passageway in the heart that connects the right side of the heart, the venous circulation, to the left side of the heart, the arterial circulation. It's present in about 25% of individuals. And by residual, we mean that it's present in utero, so a fetus has a foramen ovale that basically in principle allows the circulation from the venous side to bypass the lungs, going straight to the left side of the heart and being pumped into the arterial circulation. And so ordinarily that closes at birth in the majority of people, but in a significant minority, about 25%, there's a residual passageway that allows some blood to flow from the venous side of the heart to the arterial side without going through the lungs in between. Yeah, so then what happened is that they did population studies where people, either people with patent foramen ovale were investigated to see if they had an increased incidence of migraine, and then they looked the other way around. If you take patients with migraine, do they have an increased incidence of patent foramen ovale? And either way you look, there is an association there, meaning that there's a higher incidence of or prevalence of migraine in patients who have patent foramen ovale, and if you look at migraine patients, they're more likely to have a patent foramen ovale. But the key thing is it's specifically patients with migraine with aura as compared to without aura. So if you look at if you just separate the PFO, the migraine with aura patients, they have the association, but the patients who do not have aura as part of their attacks do not have that association. So it really seems to be something to do specifically with patients who have migraine with aura as compared to without aura. That's sort of is the next step in the process, is that there have now been done 3 randomized placebo-controlled studies of, or actually 2 of them were placebo-controlled, meaning they actually had a sham procedure so that the patient didn't know whether or not they actually had the patent foramen ovale closed. And I should say that they close it with a mechanical device that's sort of like an umbrella, where you actually put the device, they thread the device up into the heart from the groin, and then kind of open this umbrella in a way that basically closes off this passageway. So the studies looked at patients with and without aura, and none of the studies actually hit the primary clinical endpoint of the study, meaning that it showed that patent foramen ovale was effective in preventing migraine, and really either migraine with or without aura. So the complicating part is that some of that has to do with the study design and what the primary endpoints were. And kind of a rule of clinical trials is that if you miss your primary endpoint, it's not really fair to go digging around in all the other ones to try and pull out something positive. It's just sort of the rules of clinical trials. Having said that, there's very interesting data in the secondary endpoints. And so the most recent study that was done was this one called the Premium study. I was involved with it as an investigator and part of the trial design. And what if you do the sub-analysis of some of the secondary endpoints, again with the caveat that it did not hit its primary endpoint, it looks like the patients who had aura with the majority of their attacks, which is actually a minority of migraine patients, those people actually did quite well with closure of patent foramen ovale. So we're sort of in this position here where we know that it's there. It appears to be an association, but association doesn't necessarily indicate causation. So it then really comes around to the key question of, if you find a PFO in a patient with migraine, should you even consider closing it based on the fact that there's no clinical trial data to really strongly support that that path? And so I would say at this stage, it doesn't necessarily change our management of these patients, but it is something that we should really think strongly about, in terms of in the future, in terms of understanding whether this is actually playing a causative role in some patients.
So you can understand why having a sham procedure in your heart of all places doesn't sound alluring. And what I can say is I don't regret it, but the patterns did change. I mean, the migraines persisted, but the visual aura that I got when I was young, it became extremely rare after that. And I got more of the cognitive and aphasiatic aura. And I only have 3 more videos left. But the next one is Dr. Dodick again. And when I spoke to him on the PFO 20 years ago, before I had it done even, he did not believe in a causative relationship. He explained it to me that there was likely an association based off the genes, and that is something called pleiotropy, where a gene is responsible for more than one thing. And that's where the association is, the relationship. It may also be that the idea that the reason I don't have the white matter lesions in my brain is because I had the hole closed, and that the unoxygenated blood going up is what's causing the lesions and the white matter. But the other explanation is that the cortical spreading depression is responsible for it, but why it shows up in some people and not everyone else is sort of the mystery.
And we know that migraine is associated with changes in brain structure and function. We have a plethora now of evidence for this. Imaging studies have shown changes in gray matter volume, in cortical thickness, and in white matter integrity, and in functional connectivity between certain regions of the brain. And functionally speaking, we know now from a number of imaging studies that there is a change in the way a person with migraine, their brain processes information. So and electrophysiologically, we've demonstrated changes in the migraine brain compared to a brain that doesn't have migraine. So there's no question that there are structural and functional changes in the brain, and that this gets progressively worse over time the longer you live with the disease and the more frequent and more severe and more disabling your disease is. In fact, you can think of migraine as a trait disorder rather than a state disorder. We used to talk about migraine as having paroxysmal attacks of headache, or it was an episodic headache disorder. Where people are normal and their brain is normal in between. And we know now that that is not the case. So rather than a state disorder with episodic attacks, we can think of it as a trait disorder with a persistent alteration in the way in which the brain processes sensory information. And we did a meta-analysis of all of the functional imaging studies. Now this is about 5 years old, that have been done in people with migraine compared to controls. And what you can see in these illustrations here is that whether we're talking about olfaction or light or pain, the areas in yellow and the areas in blue are areas of the brain that become hyperactivated or deactivated when a person with migraine is processing a smell, a light, or pain, even in the absence of headache, and in particular in the absence of headache. So this is in the interictal state. So the way that a person's brain with migraine processes sensory information, and these are just 3, it could be balance, it could be pain elsewhere in the body, is quite different than the way a person without migraine processes sensory information coming into it. The take-home message here is that migraine you can think of as more of a trait disorder that has interictal symptoms that are not related to headache necessarily, as opposed to thinking of this as just an episodic neurological disorder with attacks of head pain in between which the patient and their brain is normal. And so taking that a step further, we see that migraine is often divided up into these 4 phases of an attack. There's the prodromal phase, where people will have symptoms, not the aura phase that we heard from Cassandra, where she may have visual symptoms or sensory symptoms or other neurological symptoms that are reversible, but other more nondescript symptoms like cognitive symptoms or sensitivity to light or nausea, for example, that precede the headache by up to 48 hours. Then there's the aura in some people, about a third of people. Then there's the headache phase, and then there's this hangover phase that people will have that may last up to 1 or 2 days. But what we don't talk often enough about, I don't think, is this interictal phase, which is present in a substantial proportion of patients, and I think much more common than we actually recognize, as we've heard from Cassandra, who presented with her abdominal pain repeatedly and went undiagnosed. So abdominal pain and neck pain and fatigue and cognitive symptoms and sensitivity to light, all of those symptoms that occur in people with migraine when they're not having a headache is due to this trait disorder in the brain and the way that brain is processing information. And so on the bottom, I showed you the phases of the moon here. The moon is always in the sky. And so think of the moon as sort of a migraine brain, where it's always processing information a little bit differently. And when there's a full moon, of course, there can be a full-blown attack with head pain. But when there's not a full moon, patients may be experiencing symptoms of migraine without the headache. And like most chronic diseases, migraine is on a spectrum. You can have patients with diabetes who lose weight and they can control their disease with diet, and you have others with insulin pumps who have end organ damage. Migraine is no different. There's a frequency spectrum here. So some people, and especially the people that I see, have pain every waking moment of every single day. They have migraine symptoms continuously. And there are other people who may have 5 attacks in their lifetime. So chronic migraine are those people who have more than 15 days of symptoms, headache, per month for at least 3 months. And we know that they're significantly more disabled than those who have episodic migraine. But recently, we've shown that people who have 8 or more headache days per month are equally as disabled as those with 15 or more days per month. So I see a time in the future where the definition of chronic migraine is going to change, because we're leaving a whole lot of patients behind here because they're not able to access certain therapies that are only approved or only available for people with chronic migraine. But as you can see here, 2/3 of people with migraine have less than 1 attack or 1 symptomatic day or 1 headache day per week. So there are a substantial proportion of patients who are less affected, but make no mistake, there's a substantial number of people who are severely affected. And largely, that has somewhat to do with the environment. It has somewhat to do with genetics as well. And Cassandra's talk touched on a bit of that, but we know that there are over 100 different genes that are associated and increase the risk of migraine. And we now know that the higher the polygenic risk score, or the more risk alleles that one inherits, the younger they'll develop their disease, the more frequent they'll have attacks, and the more severe and progressive their disease is over time. So if this is a chronic disease, maybe migraine is a preventable disease. And disease management really starts by looking at those who have milder forms of the disease and preventing them from progressing. So we know the annual incidence of chronic migraine is about 2.5%. So if you take 100 people with episodic migraine and follow them for a year, 2.5 to 3 of them will have chronic migraine at the end of that year. How can we identify those 3 people who are going to progress? Well, we know that there are risk factors that are not modifiable, such as head trauma, which Dr. Becker just talked to you about, and childhood abuse, for example. But there are modifiable interventions. And it behooves us to recognize these in all of our patients, including those who have already progressed, but especially in those who are in your office complaining of more severe or more frequent attacks. And I believe if we manage these risk factors appropriately and pay attention to them, we can decrease the risk of progression and certainly decrease the burden and even perhaps increase the rates of remission. How about the biology of progression? Let me simplify this by saying, we have an ascending pain system, of course, the spinal thalamic or the trigeminal thalamic pathways. And then we have a descending system that modulates pain. We have both a descending inhibitory system. I tell patients it's like a brake pedal. And then we have a descending facilitation or facilitatory system. I tell patients it's like a gas pedal, right? So if you want to stop the car, you need to press the brake and take your foot off the accelerator. Think of pain modulation in the same way. So we have an afferent system, right? We have the trigeminal sensory system, mainly the first division, that transmits pain impulses into the brain. And then we have a two-way system that either inhibits or facilitates that. And so you can think of the biology of migraine really as either an increase in afferent input, so an increase in traffic into the system, or decreased descending inhibition, which we heard from Dr. Becker may be at play in patients with post-traumatic headache, or increased descending facilitation. So I'll tell you, one of the most common risk factors, for example, of chronic migraine is acute medication overuse, or the frequent use of acute medicines. What do acute medicines do? They increase afferent traffic by increasing the production, the synthesis and release of nitric oxide, of calcitonin gene-related peptide, for example. So they increase afferent activity, and medication overuse actually disrupts the normal descending inhibition, what we call conditioned pain modulation in the brain. So it's a combination of events in the brain that underlies why pain becomes more frequent and chronic over time. The hypothalamus is now thought to be a generator of migraine and indeed a mediator of chronic migraine. It is sort of Grand Central Station when it comes to descending pain modulation systems. So we know, for example, that the anterior hypothalamus has been identified not only as an area, the first area of activation during a migraine attack, but in people with chronic migraine who have symptoms almost all the time, there's persistent activation in this area of the hypothalamus. And you can see that compared to controls and compared to episodic migraine patients. The hypothalamus then, therefore, may also be a target and a biomarker for response to treatment. Stress. How is the hypothalamus involved? And do we have other targets in the hypothalamus? Indeed, we do. So stress, as you know, is a very common trigger for migraine attacks. Of course, it's a common trigger and it's a common feature of many functional pain syndromes, from fibromyalgia to irritable bowel syndrome and so on. It is a prodromal feature of a migraine attack. It is a risk factor for progression. And it's part of many comorbid diseases that people with migraine have, such as anxiety and depression and bipolar disorder. And the molecular biology of stress is now being really kind of worked out and dissected. We know that the hypothalamus releases CRH during stress. We also know now that it releases something called dynorphin, particularly in the amygdala, but also in the hypothalamus. And dynorphin binds to receptors called kappa opioid receptors in the hypothalamus. And what happens when that happens? There is this activation of this descending facilitation system in the brain. So pain is allowed to ascend, if you will. So stress releases dynorphin, binds to kappa opioid receptors in the hypothalamus, and causes descending pain facilitation. What if you block these kappa opioid receptors? Well, in a preclinical animal model here that we did that and showed that this kappa opioid receptor antagonist, some of which now are commercially available, not for migraine, but for other disorders, may be a new class of therapeutics for migraine prevention. And not only that, but it may be a new class for the prevention of pain and other functional pain syndromes, particularly where stress is a prominent feature of the pain. So knowing the anatomy of pain and the anatomy of disease and dissecting the molecular basis of that can lead and tee up new therapeutic targets for the future. A chronic disease management model is really an organized, proactive, multi-component, patient-centered approach. I need a mnemonic to remember things because I'm a simple guy, but you need to use your brain when managing people with migraine. So the B stands for biobehavioral therapy, biofeedback, mindfulness, cognitive behavioral therapy, physical therapy. The R is for risk factor modification, which I spoke about, and lifestyle, diet, sleep, and exercise. A is for adjunctive or nutraceutical and neurostimulation modalities, which can be helpful. Injectable, or I is for injectable therapies like onabotulinum toxin type A, like extracranial nerve blocks, like trigger point injections. The N is for neuropharmacology, and I'm just going to say a few words briefly about new therapeutics. And the S is for support and education.
So the strange thing about hearing that is just that he gave me the break speech, even 20 years ago. The next video I couldn't resist adding just because it has the best visualization of what's happening with the cells and what's going on in the brain.
Our understanding of migraine disease has changed. While there is much yet to learn, let us review some of the most important principles about this medical condition. Migraine is a disease of the nervous system. In the past, we believed that migraine headaches were caused by changes in blood vessels in the brain. Now, it is clear that what happens in the brain is much more complicated. The underlying problem with migraine sufferers is that their nervous system is too sensitive or too jumpy. It reacts to small or normal stimulation with an exaggerated response. Those triggers may be the result of something we consumed, excess stress, a lack of sleep, or a change in the weather. And how hypersensitive the nervous system is and what triggers the nervous system varies between people. In other words, migraine disease is not a single disease, but a spectrum with symptoms ranging from mild and occasional to debilitating and daily. Why is this? Genetics play a part in migraine disease. Let's remind ourselves about how the nervous system works. If we look at what we think of as a nerve, we see how it is made up of a bundle of similar neurons. Each individual neuron has a cell body with long extensions. When specialized sensors are stimulated, an electrical message starts on its way to the brain. But it is actually the flow of the charged sodium ions into the cell through ion channels, followed by the passing of potassium through separate ion channels out of the cell, that generates the electrical signal. An electrical wave then moves rapidly towards the brain. At some point, each neuron reaches its limit, and the signal must be transferred to the next set of neurons. Here, calcium channels open and secondarily cause the release of chemicals called neurotransmitters into the synapses, where receptors on the adjacent neurons must detect the neurotransmitters and regenerate the electrical signal. It is during this complex process that mistakes can be made. Think of a genetic defect as a mixed-up message about how the cell is to make things. For example, one of the known genetic defects of migraine is one where the cell is instructed to produce a protein that cannot fold into its normal three-dimensional shape. When positioned in the cell membrane and an electric signal comes along, the defective protein may open up and let calcium ions into the cell, but it might not be able to snap back into a fully closed position, allowing too much of the electrically charged calcium into the neuron. In this case, the neuron would keep releasing neurotransmitters, and the next cell would generate an exaggerated response. The consequence is that the neuron has overreacted to a stimulus. This is not just theoretical. There are known genetic defects of ion channels in families who suffer from migraine. Additionally, research has revealed genetic mistakes affecting how neurotransmitters are made, released, and inactivated. Therefore, each individual inherits a mixture of genetic errors. This may partly explain the broad spectrum of migraine symptoms and how, between individuals, migraine might affect a lot of different parts of the nervous system, not just the pain pathways. To illustrate this, let's look at the trigeminal nerve. This nerve has branches that innervate facial muscles, temporal mandibular joint, paranasal sinuses, and teeth. When stimulated, branches of the trigeminal nerve transmit information back to the brain through the trigeminal nucleus in the brainstem. From here, this message is sent to other parts of the conscious brain that acknowledge the pain and the need for action. But for a migraine sufferer, the threshold for initiating this distress signal is lower than normal, and the amplitude of the warning is abnormally high. Cortical spreading depression. So what causes the intense headache of migraine? The current theory is that a trigger, either in the brainstem or in periphery, sets off an abnormal electrical event called a cortical spreading depression. This is a wave of electrical activity that sweeps slowly across the surface of the cortex. A cortical spreading depression first initiates flashing lights or abnormal smells, followed by an intense headache. The electrical depolarization results in a release of neurotransmitters and other molecules that cause secondary inflammation. A person then experiences light sensitivity, nausea, foggy thinking, and fatigue for hours. By mechanisms that are still to be defined, the chemical reactions of a cortical spreading depression appear to affect the dura, where blood vessels dilate and contract. Mast cells release their potent inflammatory chemicals, and trigeminal nerve fibers send signals back to the brainstem. While cortical spreading depressions cannot explain many of the symptoms of migraine disease, it is likely an important event in generating the most familiar, brief, intense experiences of migraine sufferers. Migraine has a chronic form, central sensitization. It has been observed that migraine sufferers have scarring within the brain. This may be a complication from the repeated inflammation associated with cortical spreading depressions or other migraine events within the brain. Eventually, parts of the damaged nervous system simply generate low-grade, frequent, unwelcome symptoms, such as increased sensitivity to touch or light, daily headaches, tinnitus, or diminished cognitive functions. Central sensitization partly explains why migraine sufferers have different symptoms at different stages in their lives. Also, the damage to blood vessels from inflammation may explain the higher rates of stroke in migraine sufferers. And head trauma to the hypersensitive central nervous system may make migraine sufferers more vulnerable to chronic headache syndromes. The brainstem may be the core of migraine disease. Another factor in migraine disease is that abnormal electrical activity of one set of neurons may affect the behavior of adjacent ones. The brainstem is the crossroads of much of our brain circuitry. It is here that information controlling many body functions congregates in clusters of cell bodies called nuclei. When electrical messages arrive in one nucleus, they may be rerouted to other parts of the brainstem, hypothalamus, thalamus, and cortex. These nerve centers have exotic names such as the trigeminal nucleus, pulvinar, dorsal raphe, and locus coeruleus. While the trigeminal nucleus is the control center for headache pain, these adjacent nuclei control stress, balance, mood, sleep, and the autonomic system. An example is the generation of symptoms from the nasal and sinus region. Many people mistake their chronic migraine symptoms for a recurring infection. In fact, one form of chronic migraine disease is where the trigeminal nucleus generates signals that the brain interprets as abnormal pressure or pain from within the paranasal sinuses, teeth, or eyes. Adjacent to the trigeminal nucleus is the superior salivatory nucleus. This nerve center controls the production of nasal secretions and the size of the turbinates within the nose. A migraine sufferer not only feels sinus pressure, but also experiences nasal congestion and a runny nose. The interplay between these nuclei may be another explanation for why some migraine sufferers have so many related symptoms, many of which do not involve pain. Female hormones affect migraine disease. Sex hormones such as estrogen and progesterone have a profound but poorly understood effect on our nervous system. Sex hormones affect the nervous system of all women, but for migraine sufferers, their rise and fall throughout a lifetime helps to explain why the symptoms of migraine change so dramatically for women. Estradiol, better known as estrogen, has a complicated role in our nervous system. For example, for any one neuron, there are estradiol receptors on the nucleus as well as the surface of the cell. And we know of genetic defects of both these receptors. Independent of the hormone receptors, we know that estrogen also sensitizes our body to pain. While we still have a lot to learn about sex hormones, we do know that they play a critical role in the waxing and waning of migraine disorders.
All right, so the final video is about chronification. And so migraines are about a brain crossing a threshold, but chronification is about it crossing another threshold.
I started taking care of people with headaches over 20 years ago when I was a resident at Stanford. So I've seen how this can happen. I've watched women slide down that slippery slope to disability despite the best of medications. And I myself get migraine, so I have some insights into how this process can start. And then I started getting that pain. For me, my migraines start in my neck right here, and they radiate forward, and then I get the throbbing, and then there's no more roller skating, right? I'm sure some of you have migraines, you know what that's like. And I was just super annoyed at myself. I always blame myself for my migraines, and I had actually forgotten my yoga mat on this trip. I had discovered that yoga will sometimes take away that neck pain, and then I don't get the migraine. So I just popped a pill and powered through. Felt better for a couple of hours, and then took another pill, pushed through again. I mean, I just wanted to enjoy my time with my family. I didn't want to hurt anymore. But that's how the slippery slope begins. It kind of feels like you're doing the right thing in the moment. You know, you're showing up for your family, you're beating your disease, that kind of thing. But when you have more and more migraine attacks and you have to take more and more pills, it starts to change the structure of your brain physically, and not in good ways. Those changes make it harder and harder for you to ever get your migraine disease under control. This process is called chronification, and I want every single one of you to understand what this is and why you have to take action to avoid it. So chronification is kind of like this. You know those tipping buckets at water parks? They fill up with water and then the bucket tips over and splashes on all the kids below. So imagine that people who have a genetic predisposition to migraine are born with a certain size bucket, all right? Their migraine triggers fill up that bucket like water does at the water park. So for me, it's neck pain. Maybe for you, it's certain foods. Maybe for you, it's weather changes. Whatever it is, it fills up the bucket, and then when you have a migraine, it tips over. Now, here's what we've learned. When your brain goes into chronification, your bucket gets smaller. So you get to a point where it doesn't take very much to fill up your bucket, and your bucket is constantly tipping over. You're constantly having headaches, right? Now, here's the thing that surprises people. Chronification begins when you're only having 3 headache days a week, and they might not be migraines. That's a lot of people. And many of these people don't even know that they have migraine, because estimates are that only about 5% of people have been seen by a doctor, diagnosed with migraine, and treated with migraine medication. So you could be at risk for chronification even if you've never been told that your headaches are actually migraines. And here's the other thing that surprises people. Medications are often part of the cause of chronification. When you start having more and more pain and needing more and more pills to make your pain go away, you actually get to a point where the pills themselves are causing some portion of your headaches.
So the strange thing about hearing that bucket analogy is that I've heard it before from a neurologist I mentioned in a previous video. I mean, I guess I'll tell you one. I mean, at 17, I had one neurologist that he said, "Oh, I'm going to do an experiment. Yeah, sit down." And he's like, "I'm going to give you a headache." And I was like, "What?" Okay. And so he grabs my head by the hair, shakes my head back and forth violently, and then goes back. "How does your head feel?" Now, you would think I walked out of that with just like anger or just violation and just like rage, but really that was dampered with a level. It was relief, because I knew that I needed to move on. I needed to find a better neurologist, and that's all it was. So that happened. That he did not describe the bucket analogy in that the bucket gets smaller over time with more migraines, and that people are born with a different size bucket. That wasn't part of his analogy. He thought it was sort of fixed and it was the same for everyone. It's kind of why he wasn't a great neurologist. There is one thing in that video that struck me though, which is that, and a lot of the other ones, they've all pointed this out, is that they say women get migraines more than men. But what they all leave out is that boys get more migraines than girls. So the asymmetry changes with age. So the onset of puberty, the statistics change. And what that means is that for people like me, who grew up with them, chronification starts earlier. And even when you have a more undeveloped brain. So I have a headache, and now I'm getting into chaos theory itself. So prior to its discovery, there was this belief that we lived in a clockwork universe. And from a physicist's perspective, what that meant was that if you knew all the information of a system, you would be able to predict the future state of that system. And what they learned instead was that when a system crosses a threshold of complexity, it enters a state of deterministic unpredictability. So dynamic systems in general, they can be deterministic, or they can have deterministic chaos. So for expediency and ease on my headache, I'm just going to use these bullet points. Deterministic chaos. While seemingly random, chaotic systems are governed by deterministic rules, meaning their behavior is ultimately determined by initial conditions. And sensitivity to initial conditions. So this is how it was actually discovered. When they were doing atmospheric modeling early, they noticed by accident they got a wildly different result when they repeated it. And what they noticed is that there was an input error in the tiny little fractions. They added a few little points at the end of their input information, and it completely changed the final results. And that is actually where we get the term the butterfly effect, which is that if a butterfly flaps its wings, it causes a hurricane at some later point in time. All right, so I'm going to do these two in reverse order. Interconnectedness. Chaotic systems are often highly interconnected, where changes in one part of the system can have ripple effects throughout the entire system. So this goes pretty well with migraines in terms of it having this sort of limbic phenomenon, this gastrointestinal component, and involving multiple different layers of the central nervous system. The next, emergence of order. So complex systems can spontaneously organize into patterns and structures through interactions between their components. So this is where I'd argue where cortical spreading depression fits that definition. So cells, the depolarization in cells, it's how cells communicate. So them synchronizing in a wave, they're not supposed to be doing that. That's not their natural state. So there's an emergence of order there in that creation of that wave that shouldn't be taking place. So on that note, I'm going to play a clip from a lecture series I learned a lot from. And from this I got this thermometer of complexity, which is interesting in that chaos exists on this sort of scale of complexity of behavior in time, behavior in space. And turbulence is higher up. And he pointed out that Schrödinger gave up on trying to solve turbulence and moved on to quantum mechanics because it was easier. That's how difficult of a problem it was.
The question is, when chaos occurs in the human body, or in particular in the heart, could it ever be a sign of health rather than sickness? Could chaos be good for you? In what I've just been talking about with arrhythmias, chaos seemed to be the villain. The doctors refer to arrhythmias as chaos. There's always been this thinking that chaos is terrible. In medical textbooks, there's this revered concept of homeostasis, keeping the body flat, an even keel. That is, the body has all kinds of control mechanisms for evening out disturbances. Sort of like a thermostat. If the temperature goes too high, it turns on the air conditioner. And if it's too low, it turns on the heat. You're trying to regulate the body. So doctors have been taught for a very long time that homeostasis is the body's desired condition. The idea that chaos could ever be good for the body is the total opposite of this way of thinking. And so that's the question. Could it be good for you? We've also seen, we've sort of seen one example already, right? When I talked about epilepsy, I mentioned that the normal state of the brain is closer to chaos than homeostasis. So that already suggests that in the brain, chaos might actually be better for you. At least not utter chaos, but a certain low level of chaos. But what about in the heart, which is a simpler organ than the brain? Its job is a pump. It's just supposed to beat periodically, right? So how could chaos be good for your heart? Well, that paradoxical idea that it might sometimes be good for your heart, or maybe even normally it's good for your heart, that's been proposed by a leading cardiologist, Ari Goldberger at Beth Israel in Boston. This is someone who has to be taken seriously. This is not a mathematician talking about the heart. This is a practicing cardiologist who sees patients every day at one of the top hospitals in the world. Now, Goldberger is an interesting case in that he is one of the rare medical people who has also mastered the ideas and language of chaos and fractals. That is, we've seen in this course instances of mathematicians and physicists sort of gently stepping into fields they don't know much about, like communications or biology, trying their hand to make a helpful contribution. But we haven't seen so much in the other direction where biologists were starting to learn about chaos theory. But Goldberger is a sterling example of that. Now, I've seen him give very nice lectures about his ideas. And in his lecture, he typically likes to show a graph of 4 different patients showing their heart rate variability, how much their heart rate is changing from moment to moment. And then he asks the audience with a dramatic flourish, which of these 4 patients is the sickest? So, taking a page out of his book, I'm going to try to play the same game with you. I think you'll find it interesting. So here are the 4 charts that Goldberger likes to show. Heart rate variability, measured as beats per minute. You know, you're supposed to, when the doctor checks you, you sort of expect your pulse to be something like 70 beats per minute or thereabouts, maybe 60 if you're an athlete. Well, look at these 4 patients. You're seeing their heart rate versus time, and they have very different patterns. This one is rock steady. If you like homeostasis, this person is your man or woman. Here's something that looks sort of complicated and jittery, and then it has this big bump in it. It's sort of noisy looking. Here's one that is close to homeostatic, close to flat, but it has regular oscillations in it. up and down cycles of about 1 minute. And here's one that has a lot of high frequency, jittery, jumpy variations in heart rate. So there are 4 very different looking examples. Now, take your guess. Which one of these patients is the sickest? Well, here's the answer. That one is. The one with the rock steady heart rate is suffering from a pretty serious disease called congestive heart failure. When you have heart failure, it means that your heart is failing to pump blood, sufficient blood, to the body's other organs. And what happens then is, because of the reduced outflow from the heart, the blood that's returning to the heart from other organs starts to back up, causing congestion in the tissues, hence the name, congestive heart failure. Also, fluid can collect in the lungs, causing shortness of breath. This person in panel A is very sick. Well, what about this person here in C, whose heart rate looks pretty rhythmic? It's basically flat, but with these very regular cycles to it. Predictable cycles with a time of about 1 minute. Sick or healthy? Well, that person also has heart failure and a pathological form of breathing that leads to these periodicities. It's a pathological condition known as Cheyne-Stokes breathing, in which the patient alternates between breathing very rapidly and then not breathing at all. Very serious problem for this patient. So maybe by now you're getting the idea that homeostasis as measured here is not such a great thing. Maybe it would be better to have a heart rate that fluctuates a lot, like the one in the bottom. Not quite, because that person has atrial fibrillation. Excessive randomness in your heart rate, as if it were uncorrelated from beat to beat, just independent random beats, that is also bad for you. So, well, who's left? This person with the erratic heart rate that's not quite as erratic as the one on the bottom, that person is normal. That's a healthy person. And it has he or she has a surprisingly variable, almost chaotic and dance-like rhythm, with variations from beat to beat. If we look at it, though, we can see that there is a kind of order to it. If we look closer, that kind of rhythm is a fractal. It's self-similar in time, at least in a statistical sense. It's a fractal process in time, much like we discussed in lecture 16 when we were talking about stock prices or internet traffic. And what I'm showing in this panel right here is that, well, we've seen what spatial self-similarity means, where small pieces of some structure, when blown up, look exactly like the original. Here we're seeing statistical self-similarity in heart rate, self-similarity in time, not in space. So what the panel is showing is heart rate as a function of time, but now over 3 different time windows. Take a little piece of that record and blow it up, a 30-minute piece, blow it up to be the full scale, and you see you still have this dance-like rhythm in heart rate. And blow up a little segment of that, 3 minutes long, it's still dancing. So whether we look at any of those timescales, we see the same kind of variability. And Goldberger believes that this reflects the normal workings of the healthy involuntary nervous system. To put it this way, he believes a bit of chaos is good for you. It allows you to adapt, to avoid rigidity in your physiology. And he's also shown that as we age, we lose this kind of flexibility. Our heart rate variability decreases as we age, a kind of rigidity that is not good for you.
So part of migraine therapy is biofeedback and neurofeedback. And neurofeedback is more electrodes on the head in terms of muscle, EMG, and sort of heart rate monitoring and breathing. And when I saw a neurotherapist, he looked at my heart rate and was sort of immediately in shock, just within about 15 seconds of hooking me up. He looked, I didn't have a normal heart rate variability. And, you know, my breathing was how I breathe, but he told me I had a parasympathetic nervous system disorder, and from what I understand, that is controlled by the hypothalamus. And it's another component of central nervous system dysfunction that is either a symptom of the larger dysfunction or sort of a cause. And to understand what that means, the parasympathetic is, so if you think of flight or flight response, that is the sympathetic. the parasympathetic is what's responsible for turning that off. So what that means is when my flight or flight response goes up, there's no braking mechanism to help bring it back down. And that's something I've noticed throughout my whole life, is that when something is, I get agitated or something aggressive, someone's aggressive towards me, it takes me longer to return to a baseline of just steady calmness. So self-similarity can be thought of almost as in the migraine pattern itself in terms of the stages. Nonlinearity is the brain is a nonlinear system, and if you look at the upper right, those are nonlinear functions. The top left is linear functions. This is another example of where mathematicians aren't very good at naming things. So if you imagine a zoo, it's like calling every other animal at the zoo a non-elephant. And because a linear function is pretty simple to understand, it's pretty obvious. But there is a whole diversity of other functions and of much greater complexity. And the final thing that leads us back to is feedback loops. So if you remember the triggers from this guy, they sort of encircle him, and that's kind of why I'm using them. If you can imagine them bouncing around to each other from one to the next, and on, it creates a cyclone. So I created this list, some of the relationships. So headaches cause stress, muscle tension, stress cause headaches cause stress hormones, vasoconstriction. Those all lead back to headaches. Depression causes headaches cause depression, anxiety causes headaches. I added headache advice in there because that is a unique thing, that once you're on the migraine spectrum, I still get headache advice. I still get asked if I to try ibuprofen or something. I remember going into the hospital and on the way on the train ride saying I'm going there to go to the hospital for migraines, and the person was still giving me headache advice on the train. I remember before one surgery going to Washington, D.C. and someone suggesting stem cell injections. I got advice on doing fecal implants. But also medication overuse at the bottom is important. And I changed up my medications constantly. I don't use the medications as much as I used to about a decade or 15 years ago. But even then, like, I would go a week on something and then I would cycle to a different medication, then I would go to a different, but I was using medications pretty regularly. And with my headache chart, so the way I would evaluate is that depending on what type of headache I would have, on my headache chart here, I would use a different type of medication. But I was still using a fair amount. And one of the tragic ironies is that I overuse medications in order to write. Migraine disease is one of the common primary headaches that can prevent patients from their everyday life. Despite the high prevalence, the pathophysiology of the disease has not been clearly understood yet. Here, the brain is considered as a dynamical system. The Chua circuit with a chaotic attractor is the proposed model. The attractor has a one scroll mode representing a healthy brain and a double scroll mode representing a migraine sufferer's brain. We believe that migraine disease and Chua's circuit have certain behavioral similarities. The boundaries of the attractor are the sensitive brain areas in which any small trigger can start the ictal phase of the migraine. Ictal here means the pain. The transition from the interictal phase to the ictal phase in the migraine patient occurs due to decrease in serotonin levels when the brain is within the boundaries of the first attractor. Here, this is the result of an increase of system parameters. In addition, the transition from the ictal phase to the interictal phase in a migraine sufferer brain is caused by a disruption of coordination in the brain structures, and that lasts for a certain period for every migraine patient. So I don't know that it's going to be productive to go through the whole paper like that, especially when a lot of it has math in it. But that is the circuit at the top, but I can sort of translate it. And first, why circuits? So that is part of the one accidental how chaos was discovered, when circuits have this noise problem, and electrical engineers for years tried to get rid of this noise, which is this shift in voltage that just appears randomly. And they tried all sorts of things to damper it out. It can happen with bad components, but what they misunderstood, that it was intrinsic to the system, that it was, and Chua's circuit is a circuit that was built specifically to be chaotic. It was trying to create the simplest circuit that would show chaos. All right, I'm going to do 2 demonstrations of Chua's circuit.
Look up the probes.
Here's this one.
One goes to C1.
And that is an oscilloscope.
The other one
It's an electrical test instrument that graphically displays varying voltages.
And of course, let's turn it on. Let's change the parameter. As I turn, here I have a simple oscillator, first bifurcation, and chaos. Let's make this a little smaller so we can see better what's going on. I'm going to change the other parameter.
All right, so the visual connection is pretty straightforward. In the upper left, that is a normal, healthy brain. In the bottom middle, that is episodic migraine. And in the top right, that is chronic migraine. And as you can see, the gap between the red and the blue is far tighter with chronic migraine, and it's far more set into the attractor phase. It's sort of stuck in the cycle. So this is a different paper that has a different argument, just about dynamical transitions and bifurcations. And it begins, migraine headache is the 3rd most prevalent and 6th most disabling disease in the world. I'm going to skip that, and I'm going to read pretty fast. Despite the research that has been done about this disease, the mechanism of migraine is not well understood. There are 2 main theories about migraine mechanisms: spreading depression and migraine generator theories. The spreading depression theory of migraine assumes that cortical spreading depression waves cause neurological symptoms in the pain in the oral and ictal phases, respectively. However, in migraine generator theory, a large amount of evidence supports the claim that dysfunction in the brainstem causes the migraine cycle and even the CSD waves. Many different studies have shown that neural hyperexcitability is the physiological parameter that causes the migraine cycle to initiate. Actually increasing the excitability brings the brain to a tipping point in which a migraine initiates. Mathematically, migraine is a dynamical disease containing transitions that happen because of parameter changes through the migraine cycle. To investigate the progress of this disease, computational models can be used. These models could characterize the essential involved subnetworks and their connections during the migraine cycle, which are needed to understand how migraineur's brain can reach a tipping point through increased excitability. Dynamical diseases, the extension of a periodic disease, are defined as those in which changes in physiological control parameters cause sudden transition in abnormal dynamics. Transitions between phases in the migraine cycle put this disease in a group of dynamical diseases. The concept of bifurcation can mathematically describe a dynamical disease with critical transitions. In complex diseases with distinct phases, the dynamical network biomarker is essentially a group of states that are highly deviated from each other. The biological system showed DNB as a critical transition points. A DNB which is strongly correlated to high amplitude fluctuation states has been seen in the pre-ictal phase of dynamical diseases, and migraine, in which we focus on this paper, has not been seen before. So most of this just goes over a lot of what's been described in the other videos and the hypersensitivity and the diagram showing excitability. I'm just going to read one paragraph. Chaos occurs in complex systems whose behavior is highly sensitive to initial conditions. Consequently, small changes in initial conditions can yield completely different responses. Some evidence claims that chaos exists in many biological systems, both in normal and abnormal situations, brain, heart, and kidney. According to this evidence, chaotic behavior is considered in many computational models of different biological systems. Recently, dynamical systems were categorized in two systems, with self-excited attractors and systems with hidden attractors. When an attractor basin of attraction involves equilibrium, we call that attractor self-excited. Otherwise, the attractor is hidden. Through a nonlinear dynamics concepts such as chaos, bifurcation diagrams, hidden attractors, and tipping points, we tried to make the effort to better understand the mechanisms of migraine headache. All right, the rest of the paper goes into the trigeminal neurovascular descending modularity brainstem and cortex and how they're the subnetworks of this model. So basically what Dr. Dodick was saying about the braking system. The first equation there describes the neural activity rate, and the second one is about the feedback loop. So before I explain this one, I'm just going to come back to it because that top right reminds me of something else. So I wanted to go over something called the logistic map just because I find it fascinating, and it is part of a negative feedback loop of population growth based off this equation. And when they initially came up with this, they couldn't quite get past a certain point. They didn't quite know what happened past this accumulation point where I'm cutting off the graph. And this is what happens. So the equation, you see the subscript there where the n and the n plus 1 is. What that means is it's the next iteration. So the input is the previous output. And as it goes in, it bifurcates, and you zoom in and it bifurcates infinitely. So I actually recorded that earlier before I got to this paper, but it's interesting to see how similar the bifurcation model is at the top right to the logistic map. So as I'm closing this out, I'm going to play a short clip that'll make sense in a minute.
Do you identify with chronic illness or chronic pain? I didn't think I did until recently, and now I'm not so sure. Hi everyone, Paul Mikolev here from Autism from the Inside. I've recently had an absolutely shocking couple of weeks, and it has really challenged my thinking around this. In general, things this year have been going pretty well for me. I've made a couple of big lifestyle changes, really prioritizing space and self-care. I committed myself to writing a book this year, and as part of that, I uncommitted myself to virtually everything else. I completely redesigned my work schedule so that I have plenty of time to focus on projects and transition between tasks. I've been looking after myself physically, mentally, emotionally, spiritually, and overall, things were going really well. In fact, I'd been so productive that I was a couple of weeks ahead of my YouTube schedule, even though I'd done everything possible to set myself up for success, to anticipate my own needs, to pace myself and ultimately make sure I avoid burnout. I still somehow managed to lose 2 weeks, just like that. At first, it started with a cold that led to brain fog and fatigue, so I accepted that. No problem, we all get sick sometimes. Okay, so maybe this cold is just taking a little longer than expected to go away. That's fine. By this stage, I'd lost an entire week and I thought, no worries, I'll just reset Monday. So Monday comes around and I woke up with a migraine. Okay, no problem, that happens sometimes. My migraines usually only last about 12 hours or so, and by the evening it was sort of slowly starting to let up a bit, and I thought, great, no problem, I'll just start afresh tomorrow and everything will be back on track. Except the next morning I can't sleep and I wake up with another migraine at 5 a.m. What is going on? I don't remember ever having 2 migraine days in a row, and Tuesday's migraine was twice as bad as Monday's. I basically spent the whole day drifting in and out of consciousness just trying to breathe. It's very rare for a migraine to be that bad for me, and I thought, wow, this is terrible luck, but that's okay. Hopefully it only lasts 12 hours, and luckily towards the evening it was slowly starting to ease again, and I thought, Okay, surely now the worst is over, but you guessed it, Wednesday comes around and guess what? Migraine number 3. Now I am 100% sure I've never ever had 3 consecutive migraine days in a row. That has just never been part of my experience. So as you can imagine, I'm very confused, like what on earth is happening? This is just so far outside the norm of anything I've experienced before, with no apparent trigger. I've been looking after myself, everything's going really well, and it's not just a little bit worse, it's significantly worse than anything I'd experienced before. So what is going on? This time, I was kind of right. The worst was over, but even after the migraines had passed, I still had a headache lingering for that entire week. And the challenge with a headache, it's not so much the pain, it's the fact that the brain fog makes it almost impossible to do anything productive.
That struck a chord with me for 2 reasons. The first is that I remember the shock and awe of the transition from episodic migraine to chronic migraine when I was 15. And it just felt like I'd get hit by a truck, and just this existential crisis of, I thought I understood my body. I thought I understood my disease. I thought my disease had set patterns and rules. And all of a sudden, those rules were broken. And no one could explain to me why. And it was just something I was going to have to deal with and manage on my own. And the other reason that struck a chord with me is that I just recently got a new diagnosis. And after 25 years of growing up in hospitals, I never got screened or diagnosed with autism until recently. And the idea that it has a connection to migraines, in that migraine being a trait disorder, it makes sense that there is a brain dysfunction, there is an overlap, and that the idea that this has been augmenting my disability this entire time without anyone noticing is just... And it was in part diagnosed from feedback from my writing and me noticing a few other things of just my hypersensitivity to sound when I'm not in pain. And the other reason is that it never got diagnosed is that I have non-stereotypical autism. So I know people on the spectrum, and I always compared myself against them in terms of their inability to pick up social cues, their concrete and pragmatic thinking styles, the very obscure special interest and externalized repetition. And I'm on the other end. I have hyperempathy. I can sort of identify with people who are very different from me. And I am deeply existential, and I camouflage autistic traits and mimics social norms. I socially blend in with a diffuse sense of self with high anxiety. That describes me pretty well. And it's difficult to just sort of learn this at this age in my life. So the hardest thing I deal with is internalized repetition, and this was something I had kept hidden and never thought was part of a larger condition. And it's not on this chart, but one of the other symptoms is that people with ASD who have experienced trauma use dissociations as a coping mechanism. And that I always dissociated as a means of way of getting out of being in the moment of being in pain. Escaping in my head was a means of escaping the moment of being in pain. And rehearsed speech is another symptom of ASD, and it feels like something I was programmed to do growing up in hospitals, because you'll sit there in a lobby for an hour, sometimes 90 minutes, waiting for a physician or a neurologist, and you have to prepare what you're going to say, because their only diagnostic tool is your voice. So But then I would do that in social situations because being socially isolated, I would sort of prepare what I was going to say to people before I met them. And the other glaring symptom is on my wall behind me. It's the dream catchers having artistic and visual interests and abilities. And is honestly, when I did a video conference with one of my psychiatrists, and he sort of finally saw my background, because mainly I'd been talking to him on the phone or in the bedroom. He actually saw all this, and seeing his reaction, it's part of how I got diagnosed. All right, so now it looks like I'm at the end of this after 3 months of making this video and still sort of learning how to make videos. I had to re-record most of this just because my laptop fan was drowning out the audio, and some of them I saved. That's because they were too hard to re-record. But my laptop is at 96% in terms of the hard drive just from all the videos. And I still feel that this is important, that in terms of migraines being understood and managed, that this is a central component to understanding and managing it. And not just to patients, but to practitioners who, you know, they're never going to learn this in medical school. They're not. But I want to end on a note, because I started watching the show White Lotus, and there's a few times there's been a character that has a migraine, and it's always kind of unnerving because it's always in a very specific context where they're trying to remove themselves from some social engagement or interaction. And I can't tell if they're genuine or if they're just trying to get themselves out of some social obligation. And it's strange because if someone who doesn't get migraines is looking at that and thinks that's what a migraine is, where you're able to just sit at a table and without sunglasses on and just be like, I have a migraine, go away. So I'm going to play a clip. And that's the life of being disabled with chronic migraines. And as hard as it is, it has always been somewhat that this is a fascinating disease, as horrific as it is. So I want to end on an optimistic note that my medical history feels like history, and that I don't see how a teenager today could be given trying to make decisions between dihydroergotamine injections or taking fentanyl, which I was prescribed, and managing all sorts of other narcotics and injections. That there's a completely new class of medications out there, and hopefully new resources, and hopefully at some point there'll be more than 500 headache specialists in the country to help handle as many people like me.